So my patient is a 16-year-old boy, resident of Tamil Nadu, studying in 11th grade, right hand dominant, presented to us with the chief complaint of inability to elevate the right shoulder, inability to bend the right elbow, inability to make a fist in the right hand, altered sensation of the right upper lip for 5 months duration. Patient had a road traffic accident 5 months back, sustained multiple injuries over the right side of the neck, right forearm, left shoulder region. He noticed inability to move his right upper lip after injury, following which he was taken to local hospital where he was operated for the left clavicular fracture and the right forearm fracture. And after the surgery, 1 month later, the patient had difficulty. Patient was able to move his right wrist and fingers, which gradually improved over the past 5 months. At present, the patient is able to raise his right shoulder, not able to raise his right shoulder, not able to flex his right elbow, not able to extend his right wrist and fingers, not able to make a powerful fist, absent sensation in the lateral aspect of the right arm, forearm, lateral aspect of the thumb. There is no complaints of intolerable pain in the right upper lip, no history of any other injuries like head injury, scapular, cervical spine, rib fracture, vascular injury, no history of any open wound. In the past history, there is no significant past history of comorbidities. Treatment history, he underwent surgery for a right forearm fracture and the left clavicular fracture. After 1 month of surgery, he started regular physiotherapy for the right upper lip. There is a personal history. He takes a mixed Indian diet, bowel and bladder habit normal, no addictions, no allergies. Coming to the clinical examination, patient is conscious and oriented to time, place, and person. Vitals, pulse rate is 88 per minute in the normal left limb with normal volume and character. BP is 126/74 mHg in the left upper limb with a BMI of 33.2. Physical examination, no pallor, icterus, sinuses, clubbing, edema, or lymphadenopathy. Systemic examination with a normal.
Local examination, attitude of the right upper limb at ease in standing position, shoulder elevated compared to the unaffected limb, right arms by the sides of the body, elbow extended, forearm pronated, wrist in neutral position, MCB joints extended, fingers, IP joints flexed. The examination of the neck, horizontal scar of 13 cm present over the left clavicle region, which was posed due to left clavicular fracture fixation, neck not tilted towards the opposite side, no fullness noted in the supraclavicular area. No signs of Horner syndrome, shoulder asymmetry present on the right side shoulder is elevated compared to the left side, shoulder contour wasting on the right side present. Another vertical scar 15 cm in the right forearm molar aspect due to the fracture of the both forearm which was operated. Right palm is pink compared to the opposite hand. There is a positive sulcus sign present in the right shoulder. Winging of scapula not appreciated. No break in the continuity of the right clavicle. Tenderness on tapping in the right supraclavicular area. Opposite limb normal. Bulk was slightly decreased in the right upper limb compared to the left upper limb. Tone was decreased in the right upper limb, in the shoulder and elbow joints compared to the left upper limb. Joints of the shoulder, elbow, wrist, fingers are supple on passive range of movements. Pain present during the passive range of movement of the shoulder joints. No bony abnormalities seen. There is a passive range of movements and joints. Joint control. On sensory examination, loss of sensation in the right upper limb on lateral aspect of the right arm and forearm. And there is a sensation in the C7, C8, T1 which is present on the right upper limb, but less compared to the opposite side. Motor examination of the muscles, trapezius, rhomboid, serratus anterior is of 5/5. Deltoid, supraspinatus, and infraspinatus are absent 0/5. Pec major was 4/5. Latissimus dorsi was 4/5. Biceps and brachialis were 0/5. Brachioradialis, slight contractions are present when patient trying to move the movement. And supinator was 0/5. Triceps were 4/5. And pronotor teres were 3/5, which is compared to the normal left upper limb. Then other motor examination of the wrist and the finger flexors. Wrist flexors are 4/5 compared to the left upper limb. Finger flexors, finger flexors are 4/5. Wrist extensors and finger extensors 0/5. Finger abduction and finger adduction, that is the dorsal and palmar intrusures, were 3/5 compared to the left upper limb. Thumb opponent's pollicis were 3/5. Abductor pollicis longus was 0/5. Abductor pollicis brevis was 4/5. Adductor pollicis, which is of 3/5. Reflexes, biceps reflexes are absent. Brachioradialis are absent. Biceps reflexes present 1+ in the right upper limb. Peripheral pulses, including the right radial ulnar pulses, on are normal and present bilaterally. Tinel sign is present along the course of the median and ulnar nerve, that is 10 cm below the medial epicondyal, and the radial nerve, that is 7 cm above the lateral epicondyal. This course of tinel sign was able to appreciate it. Donor sites like both the lower limbs and the chest, and that's normal, and there is no scars in that region. Our provisional diagnosis will be post-traumatic, post-ganglionic right panbrachial plexus injury, which is involving C5, C6, C7, C8, T1 for 5 months duration with absent shoulder abduction, elbow flexion, wrist and finger extension, with sensory deficit over the C5, C6 region, with partial recovery of elbow extension, finger flexion, and intrinsic signifies partial recovery over the C5, C7, C8, T1 region. We like to proceed the investigations like X-ray chest, cervical C-spine, and also we like to do the electrodiagnostic tests and nerve conduction study and electromyography, and the blood investigations are for fitness for surgery. Our management goals will be the shoulder abduction, elbow flexion, wrist finger extension. Plan of management, preoperative counseling and physiotherapy we will do, and video documentation of the movements, video recording of the informed consent with the witness along with the patient. And our plan will be exploration of the plexus, and we'll do the nerve repair or nerve transfer, depends upon the intra findings of the brachial plexus exploration. We can opt if the proximal stumps are available, we can do the nerve repair without nerve grafting. Usually we'll do C5 to posterior trunk of the posterior division of the upper trunk, and C6 to anterior division of the upper trunk. And in this patient, we can shoulder abduction with the nerve transfer. If proximal stumps are not available, roots are not available, we can do the nerve transfers like shoulder abduction, spinal accessory suprascapular. And for elbow flexion, we can do Oberlin transfer. Post-operative management and rehabilitation, we will like to do physiotherapy, follow up with the nerve conduction study and the EMG for the improvement in the movements, and video recording of the movements post-operatively, and regular follow-up, electrical nerve stimulation, and scar management we like to put to the patient. Thank you for the time, sir.
Exactly completed in 10 minutes. The panelists can start the discussion.
Can I start?
Yes, sir.
Yeah. With the permission of the others, can I start asking questions, Dr. Vijay Kumar, sir?
Yes, sir. Please start.
Yeah. Now, you have made a presentation about the clinical findings, and you also spoke about the investigations also, right? Let me ask you a few questions. when you spoke about the appearance of the palm, you said it is pink in color when compared to the opposite side, isn't it?
Yes, sir.
Why?
Sir, it could be due to the sympathetic innervation which is coming through the T1 spinal root, which can also be affected at the time of trauma. And due to the sympathetic innervation has been re-nervating, the pink, the hand is slightly pink compared to the left upper limb. Sir.
Okay. In the clinical examination, have you mentioned about the radial artery pulsation?
Yes, sir.
Yes.
Radial artery pulsation.
Because you mentioned the blood pressure in the left upper limb. But I don't remember you mentioning the blood pressure in the right lower upper limb.
Okay, sir. Right. An exam, we didn't mention
Blood
that,
pressures,
but we checked the pulse rate. We'll check in that right upper limb, sir.
You have checked the pulse and it is okay. Huh?
Pulse is okay.
Pulses.
Pulses are brachial,
Okay.
ulnar, radial are okay, sir.
Yeah. Then you talked about the sensory disturbances. Where were all the sensory disturbances? You talked about something in the palm. Can you show me that slide?
Yes, sir. Oh, sensory distance.
Yeah.
So you want the video?
Yeah, please go to the previous slide. Yes, yes, tell me. Yes. Loss of sensation in the right upper limb on lateral aspect of the right arm and forearm and thumb, isn't it?
Yes, sir.
Yeah. Now the median nerve supplies the sensation to the thumb.
Yes, sir.
So does it imply that the median nerve is involved?
So only in the lateral aspect of the thumb, sir. In the medial aspect of the thumb, he is able to identify some sensation, sir.
Does he have sensation on the index finger and the mid fingers?
Yeah, index finger, middle finger, ring finger to identify the sensation, sir.
No, I'm a little doubtful about that. I'll tell you why. Okay. Then
Ready?
you in your clinical examination, you mentioned that go to the motor examination of flexor carpi radialis. Next. Yeah. What is the power of flexor carpi radialis?
Which assess to the wrist flex, which assess before against resistance is able to do, sir.
No, I am very specific here. I want to know about the flexor carpi radialis.
Individually, we have not tested.
Individually,
yes.
Individually, we have not tested.
Why you have not tested? It's very important. Now look at the picture on the side, no? What does it look like? Can you see the picture?
Yes, sir. It is ulnar deviated, sir.
Yeah, it's ulnar deviated. Why can you expect the flexor carpi radialis to act in this patient?
Yes, sir. It will act, sir.
How will it act? What is it supplied by? What is the root value of the blood nerve supplied to the FCR?
Flexor carpi radialis is supplied by median nerve, sir. And the thing why I am accepting that flexor carpi radial work is abductor pollicis brevis is working fine in this patient, sir.
No. You cannot assume that. Please understand that the nerve supplied to the flexor carpi radialis is median nerve. Accepted. Okay.
Yes, sir.
But what is the root value of the median nerve?
Root value of the median nerve is C5, C6, and C8, T1, sir. C5 to T1.
C5 to T1. That means all the roots are supplying the median nerve, isn't it? Are coming through the median nerve.
Yes, sir.
Isn't it? So you must remember that the nerve supply to the flexor carpi radialis is coming from C6 and C7. You yourself have written that. And
Yes,
here
sir.
you have said that C5, 6, and 7 are not acting. Only C8, T1 have recovered partially. C7 has partially recovered, isn't it?
Yes, sir.
Please remember, and I just go to the previous slide where you talked about the supinator.
Yes, sir.
Yes, you have said correctly, it is 0. Why is supinator 0?
Sir, we isolated the muscle and tried, sir, but it's not able to.
You are correct. Supinator will not act. Why is supinator not acting? The answer is there.
Because it's C5, C6.
Yes, it is C5, even though it is supplied through the radial nerve, it
It's-
arises from C5-6.
C5.
So in C5-6 lesions, you will have loss of supinator function, flexor carpi radialis is lost, and also your brachioradialis will be lost. Here also you have correctly mentioned that the power is only 1. Okay.
Yes.
So you should understand why the brachioradial is not acting in this side. It's not due to the radial nerve injury. It is due to the root involvement and C5-6. So even if you get a patient with C5-6 lesion, always look for brachioradial apart from the biceps and apart from the brachialis, apart from the supraspinatus, intraspinatus, look for brachioradialis, supinator, and the flexor carpi radialis. Please don't miss that finding next time. Okay. Yes. Then you went on to investigations and suddenly you went off to, I want to ask you, clinically, do you think it's a preganglionic lesion or postganglionic lesion?
Clinically, you're thinking it's a postganglionic lesion, sir.
Why?
One evidence that dorsal scapular rhomboids is working. The other evidence is serratus anterior is working, sir. That signifies is the injuries after the this lesion. And these are two major things I am suspecting is a postganglionic lesions.
So have you done any investigations to prove your diagnosis?
No, sir. We have we have done the X-rays and just not EMG and NCS
X-ray
were
is going to
scheduled, sir.
show you whether it's preganglionic or
No, sir.
postganglionic?
Not done any
Investigation. EMG and NCS are scheduled next week. Not
No,
done,
no.
sir.
Not EMG. What is the other investigation to find out whether it's preganglionic or postganglionic?
We can do MRI, sir. MRI can do on CT.
Not can do.
I will do MRI or I will do CT myelograms.
CT myelogram. Correct. You have not mentioned that, I think. CT myelogram.
We have not done in this patient, sir.
You are not done, but you have to mention that you want to do, no?
Right.
Okay, sir.
You have to mention that you have to do a CT myelogram. Only then you can make, because I noted that your treatment, you talked about every treatment possible for a C567 lesion. You have to plan a treatment customized for this particular patient. Okay. And the other point that I wanted to say is, when you please check again the sensation on the right hand, middle index finger, thumb, and the radial side of the ring finger, because the sensory input from the radial, for the median nerve comes from C567. Okay. So in a C567 lesion, typically you'll have loss of sensation of the median nerve territory. But the median nerve motor power, which is coming from the medial root, that is C8T1, will be intact. Right?
Right, sir.
Okay, then.
You got the point?
Yes, sir. Got it.
Yeah. Okay. Over to the others.
Yeah, thank you, Dr. Karthikeyan. This is Dr. Srikanth. Can I have a go?
Yes, sir. Please go ahead, sir.
Okay. To the candidates, if you are called upon to do an investigation to know whether the lesion is preganglionic or postganglionic, one you said a CT myelo, one you said an MRI. Can you do an MRI in a patient who already has metal implants?
No, sir.
No, sir. No, we can't. Based upon the implant making, we should know about the implant making.
So it depends on the kind of implant that is used. And it's quite possible that you may not be able to do an MRI. So can you make a diagnosis based on the ENMG, whether he's got a pre or a postganglionic?
Higher resolution ultrasound also can be done.
I said ENMG.
EMG. In EMG, we can assess that. We depends upon parascapular muscles if it is working.
Okay, that is one.
It's a preganglionic. It's a postganglionic lesion because the parascapular muscle is paired in the postganglionic lesion. One in
Okay.
that way, check it, sir. The other thing, nerve conduction study also depends upon the SNAP findings. We can tell it's a preganglionic or postganglionic.
What is it about SNAP?
Sensory nerve action potential, which will be absent in postganglionic lesion, will be present in the preganglionic lesions.
So you need to qualify that statement. You can't just say snap will be present in preganglionic and not present in postganglionic. Would you like to add something to that?
Dorsal root ganglion. So in the dorsal root ganglion will be spared.
I know the explanation, but you need to qualify it by saying a positive snap in the absence of sensation
Oh, yes, sir.
signifies a preganglionic lesion.
Yes, in the anesthetic limb, a snap positive.
So
is
among the clinical features, which some of which you have described, that can suggest that probably there is an avulsion kind of an injury. Can you repeat them again? Clinical features which suggests that probably the lesion is preganglionic. What are they?
Clinical features. Not.
Hello?
I don't know.
There are features which suggest preganglionic in our case. So we didn't understand the question.
Our case.
Clinically, when you see the case, are there any clinical features that can probably give you a suspicion of a preganglionic lesion? You stated earlier. Horners is one.
But there is no fullness in the supraclavicular region, and the Horner syndrome, there is no Horner syndrome. Two features.
If you have a Horners, does it signify a preganglionic?
It's an involvement of the T1, sir, mainly actually.
What other features will tell you that it is preganglionic?
It's a anesthesia over the paraspinal region.
Okay.
And involvement of the dorsal scapular nerve, that is the rhomboids is not working. Or if
Yeah.
the is not working.
Okay.
Then it's a preganglionic.
No Tinel sign also.
Yeah, the absence of a Tinel sign in the supraclavicular region.
Yes.
And what about the phrenic nerve?
Phrenic nerve.
What if the phrenic nerve is paralyzed? Does it signify an avulsion or a rupture?
Phrenic nerve is not arising from brachial plexus, it's arising from higher up.
Yeah. But
depends upon the phrenic nerve injury whether it's avulsion or. If the phrenic nerve signifies the injury, the severity level is high.
so if the injury is severe, it's more likely to be an avulsive kind of an injury. So how do you diagnose a phrenic nerve palsy?
Phrenic nerve we can diagnose by the chest X-ray chest. We can substantiate the diagnosis, but we can identify with the nerve conduction study. We can able to stimulate the phrenic nerve region. We can see the contraction of the diaphragm. We can see, and the intraoperatively confirm the diagnosis.
I'm not asking intraoperatively. Preoperatively, one is you said you'll get an X-ray done. Is there a better way to get the X-ray done rather than a static X-ray?
X-ray with the full inspiration, sir, we can take.
Ideally, they do what is called a fluoroscopy to find out whether there's an excursion in the diaphragm instead of depending on a single X-ray. What about the peripheral pulse?
Peripheral pulses are present, sir. Both the upper limbs.
If the peripheral pulse were absent, is it likely that the patient may have a severe or a preganglionic type of an injury?
Peripheral pulse is absent, usually associated with the axillary artery or subclavian. It's usually the clavicular region or infraclavicular region will be affected, sir, in most of the time.
What about
but avulsion injuries also can have severe trauma. It can cause fracture injuries can also cause the axillary artery injuries.
Okay. So what about supraclavicular anesthesia?
Supraclavicular anesthesia signifies supraclavicular nerve injury, sir. Supraclavicular nerve injury arises from the C4. So it signifies the C4 is also injured along with this brachial plexus.
The clinical correlation is, again, it may be an avulsion kind of an injury. There are 6 or 7 clinical criteria that will give you a clue whether it is an avulsion or a rupture. Right? Now, what are the functions you said you are going to replace?
In this patient, I would like to replace the shoulder abduction, elbow flexion, primarily, sir.
Okay.
After that, and also depends upon the intra findings.
No, right. You want to replace shoulder abduction and elbow flexion.
Mm.
Do you think any other surgery will be needed after this also?
Yes, sir. Depends upon the recovery of the patient. We will decide later. Sir.
Let us assume the shoulder and the elbow recover.
Mm. Yes, sir.
Will the patient require any other procedure?
Yes, sir. We need to replace the sensation in the upper limb on the lateral aspect, and then mostly the radial nerve and the median nerve and this started to working re-innervating, and we'll wait for the further follow up with the nerve conduction study, and we'll assess the re-innervation process. If it is not improving, we may need to do the wrist extension and finger extension. We need to.
So the patient is likely to require a wrist or finger extension procedure at a later date.
Yes, sir.
But you have diagnosed this as a case of a brachial plexus injury.
Yes, sir.
Right? So how do you justify saying that the patient has got a tinels in the course of the median nerve or tinels in the course of the radial nerve?
Yes, sir. That thing, because the maybe C5, C6 is grade 5 or 6 injuries, but C7, C8, T1 will be the, according to Sunderland classification, could be of 3 or 2 or 3 injury kind of thing. So it axonotomy alone is an occurred. So it is re-innervating from the process.
See, do you think that the injury is above the clavicle or below the clavicle?
It's above the clavicle.
It's above the clavicle.
Mm.
So let us assume that your serratus anterior is working fine, your rhomboideus are working fine. So it signifies a post-ganglionic kind of a lesion. Involving which roots?
C5, C6.
C5, C6, all roots are affected, sir, but
Okay.
moreover the C5, C6 region.
Okay. So essentially, whatever surgery that you're going to do about the clavicle is going to take care of the C5, 6 roots.
Yes, sir.
And if there is any deficit regarding any other root, would you like to do a neurolysis about the clavicle, or you would go in and do a tendon transfer at a later date?
Based on the improvement.
We will do the neurolysis of the so neuroma can be done, sir. For the if any neuromas is present in the C7, C8, T1 region roots, plexus, upper and middle plexus, we will do the neurolysis. Can be done, sir, along with exploration.
If you're doing a neurolysis, how can you check intraoperatively?
We will check with the stimulation, sir. Introp nerve stimulation we will do, sir. And
So
we will assess the movements, what are the movements present in the patient intraoperatively. Then we'll decide, sir.
Okay, thank you.
Thank you, sir.
Vijay, sir.
What is your now plan?
Plan in this patient, we will.
You have to plan in such a way that the patient holistic plan you will do in stages, what you do in one stage, and what things you are going to correct. One more answer that pre-ganglionic, post-ganglionic, if you have the facility of very good radiologist who is doing good ultrasound, high regional ultrasound, he can also tell you, guide you. But now, what is your plan now? What are the problems in this patient, and how will you manage?
In this patient, I will concentrate initially on shoulder abduction and the elbow flexion, sir.
No, you have to tell this is such a period. You have to tell about the period. This much injury, and these are the things which are the problem. These problems have to be taken care.
The patient is at present is 5 months old injury, sir. So the recovery there in the C5, C6 region is not there. So we have to do the exploration and do the nerve transfer or the appropriate surgery before 6 months, because after 6 months.
What are you expecting when you explore, do the exploration? What are you expecting? whether what thing, because we told that there was a fracture of the clavicle and that was fixed, na?
Yes, sir. Yes, sir.
That's
So
on the
what
opposite
thing
side.
you
That is on the opposite side.
huh?
Fracture clavicle is in the opposite side.
Opposite side, not same side.
Yes.
Okay, so where will you explore and what you are expecting?
Sir, we'll explore the supraclavicular region with the incision extending from the anterior from the sternocleidomastoid mastoid, extending to trapezius posteriorly, transverse incision, and we'll explore the brachial plexus, and we'll identify. We'll expect in this patient, we'll expect C5, C6 roots to be injured postganglionically, and C7, C8, T1 will be the axonomous lesion, which will be the neuromine continuity kind of thing, and we will stimulate intraoperatively each roots. We will stimulate and see if it's C7, C8, T1, which is working renervating process. We'll do neurolysis and leave it. The other C5, C6, if the proximal roots are available, we'll do the nerve grafts to the distal stump with the sural nerve grafting. If proximal stumps are not available, we'll plan for the nerve transfers like spinal accessory nerve transfer to the distal spinal accessory. We'll take it to suprascapular nerve transfer for shoulder stabilization. And I will do we'll assess the phrenic nerve. We'll do the Oberlin nerve transfer because in this patient, median nerve is working and ulnar nerve, there is some renervation process is there. We will check intraoperatively with the electrical nerve stimulation, and we'll take a fascicle and renervate the biceps or the biceps, sir, for the elbow flexion.
Then
Sir.
This will solve your problem?
Sir, this will give attention to the shoulder and shoulder stabilization and elbow flexion. But once we will do further on the stage reconstruction, depends upon the follow-up.
So you have to plan in from the beginning. Is this I will do this. Then after some, how many period you will do this, then you do this. You have to plan.
Yes, sir.
Because immediately, 5-month-old injury, you have to plan whether neurolysis or nerve will be done, or otherwise, if you are getting late, you have to plan for nerve transfers. Then comes the tendon transfers. So what are your plans while you do this? Plan these surgeries, and in this patient.
Sir, we will plan first surgery by along with the exploration. We will do spinal accessory to Oberlin the first stage. After 3 months, we'll plan for the second surgery, sir.
You are saying spinal accessory to Oberlin?
Spinal accessory to suprascapular nerve and Oberlin transfer for elbow flexion, sir.
Dr. Srikanth here, I would just like to add a point to our candidates. If you get a root, you are going to graft it using sural nerve grafts.
Yes, sir.
It is very, very unusual for you to be able to do a direct transfer from C5 root to the anterior division of the superior trunk and C6 to the anterior division of superior trunk and C5 to the posterior division of superior trunk. You may have to put nerve grafts if you want to make sure that you have resected the neuroma adequately. Okay?
Yes.
Assuming in your case, the C7 and C8 T1 are injured, but they are still functioning,
Yes,
there could be a role of doing neurolysis if you are good at it and you have intraoperative nerve stimulation. Now, the problem is going to come if you don't find the proximal end of the C5 root and the C6 root. In that case, you said you are going to do a spinal accessory to suprascapular nerve transfer. That will innervate the supraspinatus and infraspinatus. You said you will do an Oberlin. Now, the Oberlin involves transferring fascicles of the ulnar nerve to the biceps branch.
Yes, sir.
But then what about the axillary nerve? If you have a patient with a BMI of 33,
yes, sir.
And you take care of only the supraspinatus, he is not going to get shoulder abduction.
Yes, sir. We can do, sir.
So can you do something?
Yes, sir. Long head of triceps branch can be taken and re-innervate the axillary nerve can be done, sir.
But
So,
by your own admission, the triceps was not normal.
triceps working, sir, in our patient.
4 by 5.
Working is not the question. If a
Hmm.
triceps is normal 5 by 5, then you are permitted to take a fascicle from there to transfer to the axillary nerve. But when you have a triceps which is 4 by 5, it may cause some loss in triceps function.
Sir, some degree of loss will be there, sir. But we are taking only the one branch that is long enough triceps and you're innervating, sir.
Is there any
triceps,
alternative? Is there any alternative to innervating the axillary nerve?
Yes, sir. Phrenic nerve can be taken to innervate, sir. Phrenic nerve can be taken, sir. And your intercostal nerve can also be taken to innervate the.
So, the choice between phrenic and intercostal, which will you prefer?
In our center we will prefer phrenic nerve, sir.
The standard dictum would be preferring the intercostal nerve, not the phrenic nerve.
Okay. Sir.
Okay. In addition, again, you know that the patient has got a BMI of 33 and a phrenic nerve cannot be used to transfer to the axillary nerve without a nerve graft, whereas the intercostal can be transferred directly without an intervening nerve graft.
Okay.
Right?
Okay.
Dr.
Okay, thank
Vimalendu? Dr. Vimalendu?
Hi, Dr. Bharat and Jacob.
Ah.
I just forget whether you had mentioned the loss of consciousness in your history. Did you mention this?
No, sir, we didn't mention. There is no other injuries we mentioned, but we didn't mention about the loss of consciousness.
I think that is one important point which you missed, and you should be mentioning loss of consciousness. The other thing is as Dr. Karthikeyan rightly pointed out, MRI is one of the very important tests you should be doing. It's not only for the diagnosis of whether it is a preganglionic or postganglionic, but also gives you a fair degree of, estimation about the degree of scarring. What is the amount of scarring that you are going to get, and how much exploration you will be needing in this patient. Like when you say you will be exploring the supraclavicular region, maybe you'll have to explore the infraclavicular region as well.
Yes, sir.
Because if the scarring is too much, then you have to go to a normal area and remove the entire scar, and then you have to bridge that area with a nerve graft. If at all you are going to do a reconstruction of the brachial plexus. The other thing is the Tinel sign, which is very important. You have mentioned the Tinel sign, but probably you have not mentioned Tinel sign in the neck. Have you examined the Tinel sign in the neck?
We mentioned it tapped in the supraclavicular region, sir, but there is no Tinel sign the patient having pain in that supraclavicular region, sir.
Yeah. Do you think it has got any importance in the diagnosis?
Yes, sir. There is some proximate stump having neuromoid continuity will have that test.
Correct. So that is one way of, getting an indication whether it's a preganglionic or a postganglionic injury, right? So if you get a Tinel's positive, that means there are some nerve root which is available for The other thing is then very important point is the counseling of the patient. This patient has come to you after 5 months, right?
Yes, sir.
Now, suppose a patient, there is a hospital where you may be getting reference for a patient who has got immediate injury, is in the ICU, and you have been called that this patient has got a brachial plexus injury. What are the investigation that you are going to do to ask, to get the investigation for this patient? Suppose it was a immediate, like a patient had a history of injury and is in the ICU, and you as a plastic surgeon has been called to manage this patient. What are the investigations?
First we'll do the clinical examination, sir, and we will do the vascular status. We will assess by the CT angiography or ultrasound or Doppler, whichever is possible. We'll assess the vascular injury, rule out the vascular injury, and the clavicular fracture we will rule out, sir. And if it is a closed injury, we won't. We'll wait for three weeks and we'll do the MRI later. If it is open injury, we will take to OT and we'll plan for a surgery, sir.
So why would you like to do an MRI? Because you will see most of the people would be doing the MRI then and there.
No, sir. After
Right.
3 weeks only we will do, sir. After 3 to 4 weeks.
Both the EMG and MRI?
NCS EMG also after 1 month only, sir. We'll do.
And what is the rationale behind it?
MRI for after 1 month is edema will be there, sir. First 3 weeks it will settle after edema. Then only the nerves will be seen easily without any artifact. NCS and EMG are done after 4 weeks because that potential fibrillations will start to appear after 11 days. Sir. It will start 7 days. It will start to appear, and it will be more after appears over the 1 month. And short P waves, which is also a significance of the denervation, that also appears after 1 month. P short waves. And also, if it is any reinnervation occurring, also we can the neuropraxica lesions and all reinnervation occurring, that will be evident only after 1 month, sir.
And most of the findings of EMG, the findings of EMG in early stages are not very clear in defining the preganglionic and postganglionic status, and that is why you need to do it after 1 month of the injury to get a clear picture of so that all these investigation and your clinical finding corroborate with each other to arrive to a diagnosis. Now, the next thing is the counseling part. When you say you will counsel the patient has come to you after 5 months. Do you think a counseling of patient who comes to you immediately after injury, after 3 months or after 5 months will be the same? What will you counsel differently in this patient, 5 months old injury?
Yes, sir. We will tell that patient there is a treatment protocol will be different based upon the time period the patient presented. But in this patient, patient presented 5 months. We have enough time to do the nerve transfers by before 9 months. But whatever the nerve transfers we do after 6 months, the results will be drastically fall compared to which is done in the 3 months, sir. It won't be as similar as 3 months period, and it is after 6 months. So explain the patient, the results won't be. We can't guarantee the results to the patient.
Correct,
what is expected.
Right. So in this patient, when you say that you are going to do the nerve reconstruction, you have already mentioned you will be doing the nerve reconstruction. Would you like to do a nerve reconstruction along with the distal or nerve transfer, or you would like to do only the nerve reconstruction?
No reconstruction of.
So when you say nerve reconstruction, I mean that you will be connecting the proximal available root to the distal part with a nerve graft. Okay, that is the reconstruction. But when you say target innervation along with the nerve reconstruction, that means when you are doing the overlay transfer or the spinal accessory to suprascapular nerve transfer along with these transfers. So would you like to do distal nerve transfer along with this reconstruction, or you would just go ahead with the either of the two?
If the proximal stump is healthy and distal stumps are able to identify, I will do the nerve grafting, sir.
Okay. So you see, 5 months is a little bit tricky because in 5 months, most of the time, you may get the good
procedure
reconstruction, but sometimes you may not get a good outcome. So maybe it's a good idea to do a distal nerve transfer also with these patients, because you're not going to harm these patients with doing a distal nerve transfer. Right?
Yes, sir.
The other thing is you have already said the wrist is has not recovered, right?
Yes, sir. Yes.
So what are you going to do for that? You said you will be doing a tendon transfer. You're waiting for the recovery and then do a tendon transfer, right? If the wrist is not good enough, right?
Yes, sir. Yes, sir.
What else are you going to do in between? Is there any thing you want to do?
Distal nerve transfers are recently they're doing, sir.
Oh, that is a part of reconstruction. Okay. You have already passed that stage. You said you will either wait, you will be waiting for that recovery, or you will be doing tendon transfer later on. Nerve reconstruction, if you want to say, that will be done then and there, or maybe after a few months, right? But if suppose you are going to wait for the recovery, then is there
wait for the recovery, sir?
Is there anything you want to do to the patient in between? No surgical.
Stimulation.
So electrical no stimulation can be done.
And
And physiotherapy, electrical no stimulation, and
Try to
splinting of
splint
the
the-
hand, splinting.
yes, you would like to splint the hand, right? The wrist extension, the cock-up splint would be a good idea. Not always with physiotherapy, you can do the physiotherapy, but some in between, you can ask the patient to have a extension splint, wrist extension splint, or cock-up splint.
Can I ask a question? You had said that if the wrist extension does not improve, you'll do a tendon transfer, isn't it? What
Yes, sir.
tendon transfer do you do?
Sir, we'll do upon the available flexor tendons, we'll take one tendon and we'll innervate that.
Flexor tendon. You have to make a plan now, no?
Sir, we will take pronator teres to ECRB or and FCR to EDC, PL to EP.
One minute. You already said that the power of pronator teres is low in
Yes,
your examination.
Yes, sir.
Secondly, I told you flexor carpi radialis is not there because there is ulnar deviation of the wrist.
Yes, sir.
This is
Yes,
a
sir.
very peculiar problem that occurs in C5, 6, 7 lesions.
Yes, sir.
Okay?
Yes.
You do not have good usual tendon transfers that are described for wrist extension. No, they are not available. The only flexor tendon available of the wrist is the FCU.
FCU, sir.
Can you take the FCU for?
No, sir. FCU I can't take.
You can't take. Why can't you take the FCU for wrist extension?
Because it is the working flexor. If you take that flexor, that daily activities will be affected in the patient, sir.
Yeah, wrist flexion will be totally lost, isn't it? That is one reason. Secondly, can you transfer a flexor of the wrist to become the extensor of the wrist? Is it what are the principles of tendon transfer? Can you transfer a flexor to become extensor?
Yes, sir. Training with the patient after transfer, the patient has to be trained, sir. Trained for
What is one of the principles of tendon transfer? You need to use
synergistic muscles.
How can the flexor and extensor of a joint be synergistic? They are antagonistic, isn't it?
Sir.
So you never use the FCU for the ECRB. You
Yes,
can
sir.
use the FCU for the fingers.
Yes,
And even here, that is the only flexor, so you cannot use it. So at the end of it, wrist arthrodesis is a viable option. Okay, so that also you mentioned wrist arthrodesis is a viable option. If you are asked why, you can always say that there are no good powerful flexor muscles to be transferred, right?
Okay.
So,
Yes.
But along wrist arthrodesis, sir, if sometimes we can, the tendon transfer can be act as a static. FCR can be can act as a static extension of the wrist, ECRB.
now the thing is, this is not a normal hand. Okay, there are no forces on the extensor side. All the forces are on the flexor side only, isn't it? You yourself said that even the abductor pulse longus is not acting, isn't it?
Yes, sir. Yes, sir.
So this FCR, which itself is a weak muscle, cannot give much of static pull.
Okay, sir.
Okay, so that is why arthrodesis is a good option. Now, basically, brachial plexus is not usually kept as an exam question, exam case for MCH plus, usually not kept. And I think that you both have answered quite well for all the questions, except for a little bit of stumbling, I think, because of you need to understand the basics more. That's all, right? That's what I feel. You both have done a good job, but a little more concentration on the basics and the anatomy would be better, would go a longer way in your presentation. All the best.
Thank you.
Yeah, I would also like to add, Dr. Srikanth here. If you do your brachial plexus case so, that doesn't matter because it's a tough case, and I think the what needs to be done varies between individuals. But getting the clinical examination is right and chalking out a plan. But examining a case of brachial plexus injury should give you a confidence of dealing with any kind of a nerve injury. Whereas this had been a case of, say, a peripheral nerve injury, you would have had to say some things in far more depth. You get my point? So your performance has been pretty good, keeping in mind that it's a difficult case. But I would still ask you to read up on what are the clinical features which can give you a suspicion of a avulsion kind of an injury, because your treatment plan changes. Also understanding that any investigation can only increase the diagnostic accuracy, but you cannot be absolutely sure unless you explore the plexus, which is probably the golden rule to identify whether something has been avulsed or not. Thank you.
Sir, can we move to the second section, sir?
Actually, 5 minutes time is there still for discussion. Any more questions?
There is
Three-
one question
three
in
more,
the
yeah.
clock.
I invite Dr. Rajendran Aite sir to ask the question, sir. You can discuss.
Yeah, I put it on the group. Good evening,
Sir.
everybody.
Good
Can
evening, sir.
we any primary nerve transfer at the time of primary surgery or wrist extension?
Then,
Could you repeat the questions, please?
can't
Can
understand.
you do any other transfer
Mm.
wrist
Yes, sir.
extension at the time of primary surgery?
Transfer club
Did
to
you
wrist.
did you examine the pronator quadratus?
Yes, sir. No, not separately, not examined, sir.
Okay. So if the pronate, because the median nerve motor function is good, I expect that pronator quadratus must be good.
Okay,
And
sir.
you can do pronator quadratus
Endless.
ERB now transfer at the time of primary surgery.
Yes, sir. We can. It will help pronator quadratus to ulnar nerve can be deep
ECRB.
branch of the ulnar nerve can be transferred, sir, for improving the intrinsic function. That
No. Pronator quadratus to ECRB for wrist extension, I am saying. Because you have no other option for wrist extension.
Mm.
And you may later on may end up with doing wrist orthodesis. So rather than that, at primary,
okay, sir.
you can add PQ to ECRB.
Okay, sir.
That is one of the tendon nerve transfer at available primarily.
Okay.
The another question I wanted to ask, if you explore the plexus and if you say we will do, the root is available and we will do nerve graft. So what are the criteria to identify what is the good root? How will you identify?
Will the root intraoperatively will identify the stumps will be healthy, vascular.
Healthy means what?
The fascicles will be seen, sir.
The fascicular definition will be seen. That is one. Another thing.
And there will be no fibrosis in that region, sir. That around the perineural fibrosis won't be there.
You have
the vascular marking over the root. No root sheath will be seen nicely, sir.
okay.
That will be
the other. Can you do electrical stimulation and see the particular muscle? Or particular nerve you will stimulate there, which is coming from the root.
Yes, sir. Can stimulate dorsal scapular nerve, sir. Can see.
You can identify the nerve to serratus anterior by going posterior to the root and see the nerve going to the serratus anterior from C5, C6 to through the scalenus medius. There you can stimulate and see whether serratus is stimulable. So that also indicates that the root is good. That's all.
And one more sign I would like to add. This is Brajesh here. Like, when you are cutting the nerve, the pouting sign is said that it's a sign of a good nerve root. So when you cut it, the nerve fascicles will pout out. That means the nerve root is healthy enough to be taken for, used as a donor.
Well, can I have a question? Hello? Can I have a question, sir?
Yes, you can ask, sir.
Okay.
Yeah, please ask.
You have a time. In fact, Arun Chaudhary from Cuttack.
Ask, sir.
Your presentations are very good. And my point is, what will be your criteria for prognostic and the timeline for a secondary surgery in this case?
For brachial plexus surgery, for every surgery, we will wait for 3 months.
This case you have already planned out. Now, what will be your criteria for prognosis? And accordingly, we go for a secondary surgery later on.
Sir, we'll done the spinal accessory to suprascapular nerve transfer and the elbow.
Already you have told it. Okay. Then what will be your period of time you wait for?
Berlin muscle transfer will work in 3 months, sir. Spinal accessory suprascapular will start to work by 3 to 5 months. If there is no improvement in the shoulder abduction after the suprascapular spinal accessory to suprascapular, we will do the muscle transfer, sir. Trapezius transfer we will do for shoulder stabilization. And the Oberlin transfer, if it is not muscle is not working, the biceps Oberlin transfer, we will plan for as the patient is having LD, latissimus dorsi is working, we can transfer the LD to the elbow for the elbow flexion, sir. In this
What about the free functional muscle transfer?
In this patient, LD is working, sir. We will use the LD for the elbow flexion.
Okay.
But if it's not working, we will do the free function.
How objectively you can assess?
Sir?
How objectively you can assess this patient? What investigation objectively you can make out for?
No conduction study will follow up the patient, sir. No conduction study in EMG. EMG also will do one.
Okay. What type of electrical stimulation you do post-op? Faradic or galvanic?
Sir, Faraday initially with galvanic stimulation and post-surgery with the Faraday current stimulation, sir. Okay. Muscle is stimulated by the galvanic current, sir. Nerve is along the nerve roots, it will be stimulated with the Faraday current, sir.
Okay. You know what is SD curve? Standard duration curve.
Yes, sir. We will not sure, sir. Not sure.
Okay. That is to know the muscle is affected or the nerve is affected. There is a standard duration curve. Physiology, Samson Wright, you can make out how detailed it is being done. Okay. That is very much useful also in case of all the physiotherapy people, they used to do it. Okay. Thank you.
Yeah, Dr.
Now
Bharat.
PG's interact.
Yeah, can I just add one point?
Vimalendra?
Yeah, ma'am. Vimalendra.
Okay. Add, please.
Yeah, Bharat and Jacob, you see the timeline you gave now for the spinal accessory to suprascapular, it's too less, you said 3 months, right? 3 months is too less. Practically, you will get those function only after, say, 6 to 7 months. So when you are counseling the patient, also give them a timeline of 6 to 7 months, at least for the recovery of those functions, right? For Oberlin, yes, you can say 3 months, but for spinal accessory to suprascapular, it will be more than 6 to 7 months.
Now we'll end the discussion with the panelists and invite the teams to ask the questions to the presenting team. Each team will be given 2 minutes. The team 1. Your time starts. So you have to ask question to team 2.
Yes, ma'am. Good evening, ma'am.
Yeah. You ask directly to the presenters.
Yes, ma'am. What is L-episco procedure in brachial plexus? L-episcopo procedure, modified L-episcopo procedure for brachial plexus.
I don't know, ma'am. Sorry. Can you answer this?
Team 1 has to answer the question.
Yes, ma'am. It's done in case of pediatric brachial plexus injury to correct the external rotation deformity, whereby the insertion of latissimus dorsi and the teres major tendons is being rerouted to the posterolateral surface of the humerus.
Okay. That is kind of what code you are telling, what code procedure. Oh, okay.
Okay, ma'am. Thank you, ma'am.
Okay, panelists, that question and answer both are acceptable.
Yeah, let's put it this way. When originally the Lepiscopo procedure was described in a pediatric brachial plexus injury, the functions that needed to be replaced were shoulder abduction and external rotation, because invariably what happens if a patient has not undergone surgery and there is some degree of spontaneous recovery, what happens is the adductors and the internal rotators get innervated. So the limb goes into an internal rotation adduction deformity. Now the only way you can restore it is the presence of the latissimus dorsi and the teres major. So in effect, what you need to do is you have to use the latissimus dorsi as a shoulder abductor and transfer it to the supraspinatus. The teres major, either you can use it to transfer it to the teres minor, or when you do it as a conjoint procedure, you transfer it to the infraspinatus, because the external rotators are either the infraspinatus or the teres minor. So that is actually the Lepiscopo procedure, in which there is restoration of shoulder abduction also. It is not exactly like the Mortbot procedure. This was described a long time back and is preferred in partial brachial plexus injuries who have not had the benefit of primary nerve surgery.
So
Okay.
team 1 gets the marks, but presenting team cannot.
Yeah.
No, sir? Okay. Now team 3 has to put the question. Team 1 is MMC. Team 3
Hello.
from KGMU.
Hello, ma'am.
Yeah. Ask
Good
the
evening,
question.
ma'am. Yes. My question is, how will you classify the brachial plexus injury?
Depends upon the ulnar classification, Leifert classification is there. Because preganglionic, postganglionic, clavicular and retroclavicular, supraclavicular, retroclavicular. And we can classify as preganglionic, postganglionic injury, and also we classify as upper plexus, middle plexus, lower plexus injury, or panbrachial injury.
Okay. That supraganglionic and infraganglionic trunk and cord is Millesi classification.
Okay, Millesi classification. Thank you.
Not Lippert.
Okay.
Lippert
Panelists?
classification.
Millesi classification, ulnar classification. Millesi classification, I'm not sure about the classification.
Okay.
You answer.
According to Lippert classification, it is based on mechanism and level of injury and is divided into four. First, open type of wound, and the second is closed, third is radiation induced, and fourth is obstetric. And Millesi classified is divided into four: supraganglionic, infraganglionic, the involvement of trunk and involvement of cord. And other is the classification on the anatomical location of injury, that is upper plexus palsy, lower plexus palsy, and pan plexus palsy. Okay, thank
So
you.
both teams will get the marks.
Thank
Isn't
you.
it, sir? Panelists accepted?
Yeah, except give both of them, but I would ask
Yeah.
them to look at the David Chuang classification, which is described in the recent Nelligan also.
Okay, sir.
Okay, sir.
And if you really want to classify brachial plexus with respect to this particular presentation we have had, it is not fair to include OBPI there or an open brachial plexus injury. So essentially, the team that answered have answered reasonably correct.
Okay. Now team 4 should put a question to presenting team.
Madam, we are from Stanley Medical College.
Yeah.
Doctor, with regard to this case presentation, the patient had a significant weakness of the FCR and only the FCU is acting. So are you justified in saying that you will do an Oberlin transfer where you will transfer the ulnar nerve fascicle to reanimate the biceps? If that is,
Yes.
can you justify it and can you give other
Yeah,
alternatives?
we can justify. We can during exploration, we will dissect the ulnar nerve and we'll
Yes.
stimulate the ulnar nerve. I'll take only fascicle of the one of the fascicle which is strong flexor of the wrist, and we'll during intraoperatively we'll stimulate and see if it is working. We will transfer that to.
Yes, I agree. But FCU is already working in this patient. What I'm trying to say is FCR is not working. So you will essentially be using the only working flexor to reanimate some other muscle. So how will you justify that?
Then we'll also stimulate the median nerve and see median nerve. If there is a median nerve having a strong fascicle, anything, we will take that fascicle and innervate the biceps. We'll intraoperatively we decide, depends upon the availability of the fascicle.
Okay.
Yeah, I would like to mediate on that. The question is
Yes,
an
sir.
excellent question, but the answer is an inadequate answer. The person
Can
who
I
asked the
answer,
question.
sir? Can I answer, sir?
Yeah,
Please.
yeah, please.
Sir,
Sir,
here,
let her answer because she will get marks for that if she answers well.
Sure.
Sir, here clinically the FCR is weak. So I would be very wary to use the FCR even if it is stimulatable. It will not be powerful enough to reinnervate the biceps muscle. And since recovery has not happened yet, and one justification for still doing an Oberlin would be that the patient does not have recovery of wrist extension. So ultimately, I will be doing a wrist arthrodesis, which can be one of the justifications. Or otherwise, I will go for other motor nerves for neurotization of the biceps, such as I can use the intercostal nerve also to neurotize the biceps.
Srikant, sir. Hello.
Can you hear me?
Yes, sir. Please, sir.
Yeah. So this lady who has asked the question should get marks, and for answering
Okay,
also
sir.
she should get marks.
Yes, sir. Yes, sir.
The reason is the question posed to the candidate was, you are going to stimulate intraop and you suddenly find that it's not adequate. Unless you have a preoperative plan foreseeing this condition, you cannot suddenly walk into an intercostal nerve transfer. So the preoperative examination of the hand is very essential. In fact, there are studies that do preoperative dynamometry to judge the strength of finger flexion, because that's an indirect evidence of the adequacy of the ulnar nerve to be able to donate a fascicle. Unless you have made the plan preoperatively, intraoperatively, you will be left at a risk. And 5 months, young patient should do reasonably well with an intercostal nerve transfer to the biceps branch of the musculocutaneous nerve. This is regardless of whether you're planning for a fusion at a later date. It may so happen that if you don't touch the ulnar and median nerve, the grip strength may improve. As we said, it's a lesion in continuity. But if you take the fascicle, the chance of improvement of hand function gets compromised. That problem does not lie when you transfer the pronator quadratus, because it is anyway not going to do anything if you want to innervate the wrist extensor. Thank you.
Thank you, sir. Team 5.
Ames New
Team
Delhi.
5.
I think they are not there.
Is team 5 available?
Yes. Yes, ma'am.
Yeah, please put your question.
Yes, ma'am. Ma'am, I would like to ask the minimal invasive approach techniques for brachial plexus treatment.
Bharat. Jacob.
Endoscopics are described there, but I have no idea about.
I'm sure.
Robotic surgery, minimal is expired, endoscopic and all, but I have no idea.
Pardon? Sorry, you were not audible.
Endoscopic and
You
robotic
can
surgery
answer.
described in literatures, but I have no idea about that and what we're expecting. I'm sorry, I don't know.
Yes, ma'am, he is right about robotic surgery. Can you just name the type of approaches?
Axillary, I'm not sure. I don't want to do any wrong thing.
Ma'am, should I answer?
Yeah, please.
So we have supraclavicular approach and transaxillary approach. Supraclavicular approach is it is a bit easier when compared to the transaxillary, and in humans, transaxillary approach is yet to be conducted. Only in cadaveric studies it has been done, and in India, ma'am, AIMS is started with robotic surgery also.
Oh, okay, nice.
Dr. Lakshmi,
Yeah.
I
Sir,
would probably ask you to cancel the question.
sir, tell
One-
me, sir. Why?
It's not fair. It is not mainstream. And it takes away from the importance of a plexus exploration in a complete plexus injuries. If I were to
Yes,
give
sir.
an answer to this question, I would describe a procedure which was described by Dr. Rakesh Kazanchi, where you can do an endoscopic harvest of the phrenic nerve to transfer it without a nerve graft to the musculocutaneous.
Yes, sir.
Okay.
There, the endoscopic approach is only a part of a generalized operative approach. Because you need a long length of the phrenic nerve, and
Yeah.
do endoscopic, then the access becomes easier. You need a cardiac surgeon along with it.
Yes,
And you transfer it to the musculocutaneous. Number two, recently I had an occasion to go and watch someone doing robotic surgery, and they used a 3-port approach for a diaphragmatic hernia, of which one port had to be inserted through the thorax. If you are called about to do an intercostal nerve transfer through a thoracoscopic approach, it is extremely easy, but that will be only in combination with an open procedure, because the intercostal nerves lie, they are visualized very well from the outside, inside, and normally an intercostal nerve transfer, when you go by the external approach, requires a huge incision and huge dissection. If you have endoscopic, you can harvest as many number of intercostal nerves and then bring them out through a tunnel and directly co-opt it to the musculocutaneous nerve. Other than these two indications, I would not really support the use of endoscopy in plexus injuries, at least as far as exam goes.
Partially, the presenting team answered endoscopically. And the question asked by the team 5, she wants the minimally invasive procedures. She did mention for this case, sir.
Yeah.
So 50-50% we can give.
Sure.
Yes, sir. We can't cancel, but it is also maybe future what will be the advancements we don't know. So both teams will get marks.
Absolutely.
So yes, sir. Team 6, please.
Good evening, madam.
Yeah, please.
This is Dr. Nagmalesh from Bangalore Medical College.
Yeah.
Yes, doctor. As you said, there is a SAN to SSN for shoulder to achieve shoulder abduction. So if you do a SAN to SSN, so what will be the maximum abduction angle you can achieve? And
achieve
what
up
is
to 15 to 20 degrees we can achieve, not more than that.
okay? What is dual nerve transfer for shoulder abduction?
Along with the SA to SSN, we can do Somsack procedure, that innervating the long head of triceps to the axillary branch.
Okay. So compared to single nerve transfer and dual nerve transfer, which is the better and why?
Dual nerve transfer is always better, but it depends upon the availability of the donor nerves. The radial nerve is working and if it's available, we can do the neuronal transfer. And it also helps in the external rotation also it will provide in the neuronal transfer.
And angle of abduction, you can achieve.
Angular abduction also will improve, correct. Angle of abduction also.
90 degrees. Okay, correct.
Any supplementations from our panelists?
No, it's a fair enough answer for the exam.
Okay, sir. Team 7. Put your question to presenting team.
Hello.
Yeah, please.
Yeah, I'm Team Saptajan. So
Yeah,
my question is, if intraoperatively, if you found the neuromine continuity, how will you proceed whether to do neurolysis or resect the neuroma?
Ma'am, sorry to interrupt.
Yes.
I
Yeah,
think Saptajang is team 8, ma'am.
What is team 7?
Team 7 is CMC Vellore.
Is it available?
Because the marks will be given to the other team. That's why I just want to clarify.
No, Saptarjang we wrote. Okay. Team 7, CMC Vellore is available?
I don't think so, ma'am. Nobody has responded.
Okay. Team 7 is absent. Team 8, Saptarjang, continue.
If the neuromine continuity is there, do the neurolysis and we'll see the stimulation. If it is stimulatable, distal muscles are stimulatable, we will leave the neurolysis and leave it. If there is no stimulation in the distal muscles, we will resect the neuroma and we'll do the nerve grafting.
Okay.
Satisfied?
Yes, ma'am.
Okay.
Can I add a point?
Yes, sir.
Always remember that neurolysis is probably even more difficult compared to nerve grafting, nerve transfer, everything. Neurolysis requires a huge amount of judgment. And as of today, there is only one particular reference where they say that if you have quantitative nerve conduction studies intra-op and you have identified the site of the neuroma, you stimulate the nerve proximally, you stimulate the nerve distally. And if the drop in nerve action potential is more than 50%, then you resect the neuroma and put a nerve graft. If it is less than 50%, then you are permitted to do a neurolysis. That is probably the best answer. So as you can see, you need quantitative intraoperative nerve conduction studies. Just by using a stimulator, you really can't make out whether your neurolysis has made any change or not in the immediate peroperative. There may be a post-operative improvement, but if you want to know an absolute answer, you need intraoperative nerve conduction study.
Thank you, sir. Team 9. Team 9.
RML, madam, but I don't think so.
RML, please.
Yes, ma'am. Good afternoon, everyone. Yes, ma'am. I just wanted the presenting team to highlight what are the levels of the brachial plexus and clinically as to where do we find these respective parts of the brachial plexus.
Anatomy, you mean?
Anatomy.
As in roots, where do we find the roots? What is the plane where we actually find the roots? Where do we find the trunk?
Roots will be it will be between the scalenus medius and the scalenus anterior muscle. Roots cannot. We have to resect the muscle, dissect the scalenus anterior muscle and also elevate. Then only we can see the roots.
Okay. The trunks?
Trunks will be in the supraclavicular region and posterior triangle, and the cords and cords and distal nerves will be in the infraclavicular region. We need an infraclavicular approach to below the pectoralis minor. We have to dissect and identify the distal cords and nerves.
Okay, so yeah, so the roots are actually interscaling in position. It is basically the anterior and the middle scaling, to be precisely, and trunks are in the posterior triangle between the sternocleidomastoid and the trapezius, and the divisions are
behind the clavicle.
Yeah, the divisions are formed behind the clavicle, and the cords
And the
are and the
and the
divisions
cords
are
are
below the column. Yeah, below the
behind
clavicle. Right, right. Yeah. Thank you.
Okay. Team 10. Team 10.
Ma'am, we are not sure of which team number, ma'am. Can you name the college, ma'am? Sorry.
Rohit, please tell the college.
1 minute.
Okay, go with the college, no problem. That is better.
Ma'am, I'm from Sai Karthik from KMC, ma'am. Good evening, everyone.
Yeah, please.
My question to the team members would be, what are the other nerves which can be taken as donors? So you have already mentioned like Oberlin procedure, and what are the other donors which can be taken?
For the innervation of
elbow, for the innervation of elbow, yeah.
Innervation of median nerve can be taken. Median nerve fascicle can be taken.
That comes in Oberlin. Okay. Other options?
Intramuscular, intracostal nerve can be taken. Phrenic nerve can be taken.
Okay. Anything else?
Contralateral see some that in this case it won't be appropriate.
You're asking in general.
Okay. My actual question is in contralateral C7. That is the answer which I was expecting, because others have all were discussed. Yeah, contralateral C7. When you want to innervate the elbow, what is the nerve graft which you will be using?
We'll use the vascularized ulnar nerve graft, but that won't be appropriate in this case.
No, I was asking in general.
In general, we'll vascularize ulnar nerve graft. We will use
to innervate which muscles?
We can innervate the musculocutaneous nerve with the vascularized ulnar nerve graft, and also the median nerve also we can innervate distally.
Okay. Thank you. That was the question. Thank you.
Any other college team?
He's from which college, ma'am?
He is from Kilpack Medical College.
He's team number 11, madam.
Team number 11. Who is the 10?
BJMC Pune.
BJMC Pune. If it is not there, next team.
Team 12,
team
madam.
Number 12.
New Delhi.
What is 12?
MAMC. Maulana Azad Medical College, New Delhi.
New Delhi.
Good evening. Good evening, all.
Yeah. Please put your question.
My question to the presenter is: when we are using a triceps motor branch transfer, why we are transferring it to the anterior branch of axillary? No, not to the posterior branch. And why?
Because anterior branch supplies the axillary.
Why anterior branch, not the posterior? So,
because both anterior branch supplies the deltoid anterior and middle fibers, so it helps in elbow flexion. And actually, we do all the 4 nerves here.
Actually, there is a multiple modifications.
No, if you want to select anterior or the posterior. If you want to select anterior or the posterior, people will say you select only anterior. What is the reason behind it?
Because the regiment branch will be innervated with that. Sensation also will break out.
No.
Because elbow flexion is more important than the
elbow flexion. They are asking deltoid and axillary nerve. You're asking axillary nerve innervation only. You're asking, like?
Yeah, yes, axillary nerve, anterior, posterior. I told you, you choose anterior. Why?
Not sure of that. No,
can you answer? Can you
Because,
answer?
you
Yes,
can
ma'am.
answer,
Because,
please answer.
Yes, because while innervating, anterior is mostly pure motor and posterior have some sensory component also. And most of the deltoid being supplied by anterior division. Anterior division can supply the mid and posterior deltoid also. So it is not vice versa with the posterior branch. So you always select anterior branch to nerve transfer of nerve referral.
Okay.
So we are pretty sure the deltoid is connected with anterior. It is not the case with posterior. So you always select anterior division of axillary nerve.
Okay.
Mostly.
Okay.
Any contribution from panelists?
Yeah, she gave the right answer.
So presenting team will not get the marks.
No, the questioner gets the marks.
Okay.
Ma'am, team 13.
Next team.
13, madam.
Huh?
Yes, Faridabad.
Faridabad.
Yes, I see.
Yes, I see Faridabad. Absent?
I think they are absent, ma'am. Now, team
Okay.
15, SRMC Chennai, Sri Ramchandram.
SRMC Chennai. PGs from SRMC.
I don't think we have them. Now,
Okay.
we move to team 15, madam. AIMS
Yeah.
Bhubaneswar.
Good evening, ma'am.
Yeah.
My question is, I'm from AIMS Bhubaneswar.
Yeah.
My question is, when do we observe rhomboid muscle activity in electrical studies despite the presence of C5 avulsion preganglionic injury?
Could you repeat the question? When do we get the rhomboids innervation?
In the presence of C5 avulsion preganglionic injury, when can we observe rhomboid muscle activity in electrical studies? In which condition?
When
Is there
the
any
mechanism of injury is
Post-fixed plexus. It will be a prefixed plexus. It will be a prefixed plexus. No, it will there, I think.
Yes, in case of a prefixed plexus, which receives significant innervation from the C4 nerve.
I think we finished all the.
Ma'am, we have one more team, that is team 16.
One more? 16. Okay.
AIMS Rishikesh. Is there anyone from AIMS Rishikesh?
Yes.
Aims-
Hi, everyone. Yeah. My question is, in one of your question answer, you told that you will use either median nerve or ulnar nerve for this musculocutaneous nerve reinnervation. So which nerve will be preferred in between these two and why?
Ulnar nerve will be preferred between these two. Median nerve will be won't be if the fascicle is null, we'll take the median nerve, but median won't be preserved because it will be innervating the opposite action muscle. That will create confusion in the patient during the surgery. Second thing is, in this case, second reason we can tell is in this case C5, C6 is also injured. Median nerve is also contribution from the C6. So that also will be a reason we'll take the ulnar nerve. Another reason we can tell is ulnar bicep nerve to biceps will be branch will coming in the upper part of the arm. The ulnar nerve will be close in that region, which fascicular dissection of the ulnar nerve will be very minimal when you will innervating the biceps muscle compared to the median nerve.
But what are the anatomical points?
Anatomical relation. That's all we know.
No, why ulnar nerve? So what are the anatomical points?
Anatomical, that is relation to the biceps, nerve to biceps is that is arising from the musculocutaneous nerve, which is closer to the ulnar nerve in the upper part of the arm. It's easy to do the fascicle dissection of ulnar nerve, take the branch and innervate the biceps nerve.
and motor fibers in ulnar.
And the axons, motor axons will be more in ulnar nerve.
Yes, that's the reason. And ulnar nerve has larger we can sacrifice larger diameter of ulnar nerve as compared to median nerve. Okay.
Wonderful. All teams very well interacted with the presenting team. So this session completes with this. And any questions from delegates or faculty,
Hi,
participate.
ma'am. Good evening, ma'am.
Yeah.
Ma'am, this is Dr. Bala from CMC Vellore, ma'am. He had a network issue. That's why he couldn't ask the question, ma'am.
Okay, you ask.
Team 7,
I'll
madam.
give time. Team 7. Yeah.
Team 7 CMC
Yep.
Vellore.
I just want to ask what's the arterial supply for the brachial plexus, ma'am?
So branches from the vertebral artery and some vessels will come from the transcervical artery will come, and it is near to the axillary artery. Actually, brachial plexus is surrounding the axillary artery. Some direct branches will come from the axillary artery also.
Are there any explained zones of brachial plexus based on the arterial supply?
Not sure, sir. Thank you. Not sure. Can you answer this?
Yeah, actually, there are 3 zones. From the roots to the proximal trunk.
Okay, sir.
Second is the distal nerve trunk to the proximal cord.
Okay, sir.
Third is from the cord to the terminal branches. So first is from the, as you said, it's from the vertebral artery and deep cervical artery. Second is from the subclavian artery.
Okay.
It can be a direct branch from subclavian or from the dorsal scapular.
Okay.
Third is from the direct branches of the axillary artery.
Okay.
Yeah. Thank you.
Both teams are correct. So both will get the marks. What about any other absent teams now available? 13, 14. If they are not present. Any questions from audience or, delegates, other participants? Then we go to the next session, Potter. Presenting team, only 10 minutes, please. Just diagnosis and management.
Madam, it's a photo showing elderly female lesion in the
lower eyelid.
Could be most probably basal cell carcinoma.
Malignant could be the malignant lesion of the lower eyelid.
Most probably basal cell carcinoma.
And we
would like to proceed with the management. We would like to investigate by doing a biopsy, and at the same time, we would
we'll do the blood investigations and we'll plan for a surgery. In this patient, we'll do the 3-dimensional resection of the tumor.
Micrographic.
It's a high risk tumor. High risk tumor need a wider resection. 1 centimeter face lesion. It's a lesion will exceed in the margin of 1 centimeter because it's in the high region involving the face, and we will excise the tumor, will create the defect which is of involving the inner lining of the lower eyelid and the dorsal plate and also the outer covering. So this lesion will have the defect of total more than 50% of the lower eyelid. So we'll rephrase the inner lining with the mucosal graft or septal and dorsal plate with the cartilage from the ear, and the external lining with the cheek rotation flap. Mustard cheek rotation flap will create the external lining for the lower eyelid.
Panelists can put your discussion, please. GK sir.
Will you just look at it? Will you get any other specialist opinion before you go ahead with surgery?
Because the pigmentation is there, we have to melanoma, metastatic workup and all we have to do.
Any other specialist?
Surgical oncology.
Will you get a Something else? The important structure nearby, you need to prove whether it's working well or not.
Ophthalmic consultation.
Yes, never forget that, please. Okay, you should get an ophthalmic consult. Right. Okay, so now you have said that you're going to do a Mustard's cheek rotation flap, isn't it?
Yes, sir.
Yeah, that is going to be for the cover. And what did you say for the lining?
Lining will, one thing we can, from the septum, we can take along with the septomucosal graft. If not possible, we can do the buccal graft from the buccal line, inner lining, and the cartilage graft from the ear for the septal reconstruction.
What are the principles of eyelid reconstruction?
You have to provide the proper closure of the eyelid and replace the anatomical landmarks. And
how many lamellae are there?
Corneal dry cover should be covered. This cornea should not be exposed.
It should be covered. No, the eye should be covered. So how many layers are there in the eyelid? You have to reconstruct.
Sorry, inner mucosal lining, dorsal plate, and the external cover, sir.
Okay. If you break it down into 2 layers, can you break it down into 2 layers?
Anterior and the posterior lamella.
Anterior and posterior?
Lamellae.
Lamellae. Right. Now, when you talk about reconstruction, why did you say you want to put a graft for the mucosa and a graft for the tarsal support, whereas you want to give a flap for the skin, isn't it?
Yes, sir.
Can you put a lamella for I'm sorry, can you put a buccal mucosal graft and then a tarsal cartilage graft and then a skin graft on top?
No.
No, sir.
Why?
There's the cartilage, live tissues only skin graft will work, sir.
So you should remember when you're asked about the principles of eyelid reconstruction, the 2 lamellae must be reconstructed, an anterior lamella and posterior lamella, of which one at least should be a vascularized cover.
Yes.
Right? You got that?
Yes, sir.
Yes, so one should be a vascularized cover. So you're given the anterior lamella as vascularized cover, posterior lamella you put a graft. So that is accepted, right?
Okay.
Okay. Now when you're doing a Mustard's cheek rotation flap, what are the problems that you might encounter?
One thing we can get a scar, sir. Scar problem will be there.
Scar. Then more importantly,
dog ear will be there, sir. That in the angle of nasolabial thing, some trapdoor scar kind of thing. Trapdoors.
What else will happen in the long run? What will happen to the lower eyelid?
Pulling ectropion.
Ectropion, why?
It's a pulling of the low muscle.
What muscle?
Scar contracture.
Scar contracture, anything else, something more simple. The answer is very simple.
Pulling of the facial muscles.
No, have you done
platysma contraction.
Gravity can cause
you took the platysma in your flap?
No, sir, not
so simple gravity will cause the
yes, gravity.
Yes, that is correct.
Gravity. Okay?
Yes.
It'll just drag down due to gravity.
Yes, sir.
So how do you now you have to expect it and do something. What can you do?
We'll do a sling along.
Yes, that is one thing that you can do.
The quilting sutures.
When you're suturing the flap, when you're giving the
quilting sutures, we can do.
What is quilting sutures?
Well, to reduce the space between the space and it's fixing the.
We can also teach the flap to the psychomus.
Can it's the flap. Bony structure.
Yes, that is you need. See, quilting is something you do in between, isn't it? Can you put sutures through the middle of the flap? It's not a graft, no? So what you need to do is suture the flap edge. with the mucoperiosteum. The periosteal sutures to hold the flap up in place and reduce the amount of gravitational pull. Okay. Right.
3 more minutes is there. Dr. Srikanth, Dr. Vijay Kumar, anyone would like to ask?
You directly said this is BCC. What is the differential diagnosis? You said melanoma and the other differential diagnosis.
Could be the any malignant tumor, sir, or it could be the nevus sebaceous.
So, hello?
Sir.
What was the margin for this resection? If it is BCC, then?
BCC for less than 2 centimeter, we can do 0.5 and 5 mm margin, sir. More than 2 centimeter, 1 margins.
No, 2 centimeter, 1 centimeter, 0.5, you have to choose one. Na?
Once,
so it is in the high risk area, and also, so the margin will be more than 0.6 mm.
We'll take 0.6 mm, 6 mm margins.
Okay, usually it is 5 to 6 margin. Okay, and you have said mastotic. What are the types of BCC? And which type of lesion is this?
High risk features like nodular, superficial, commonly are nodular, superficial, and morphiform squamous type and infiltrative type of the sir. Pigmented BCC also is there. Adenoid BCC.
Which type is this, you think, by seeing the picture?
Pigmented BCC.
There is no ulceration there?
Yes, sir.
In the center, see, there is a, looks like ulcer.
Yes, sir.
Squamo, bacillosquamous type.
Central ulcer, that is the field fire appearance.
Field.
Pigmented ulcerative type.
What is the peculiarity of BCC? You should know. What is, how will you?
Rodent ulcer.
No, you have to define. If you have to define in the exams, how will you define
locally
this
invasive?
ulcer?
Locally invasive.
No, not locally. Yes, you have to squamous cell. You have to say everted edges or is this?
Beaded edges. Raised
Time
beaded
is over.
round edges.
Okay. To next spot.
Time is over. Next.
It's this is a 3D CT skull of the patient. I was giving lateral and frontal views. Suggestive of LeFo2 fracture, sir. LeFo2 with the depressed frontal bone fracture also there. And there's a nasal bone fracture. It's extending to the inferior orbital rim and it's involving the maxillary bone, and it's laterally involving the maxillary buttress sutures, sir, pterygomaxillary region. And it's a pyramidal shaped bone kind of is fractured. It's a LeFo2 fracture. I will like to manage this patient in the emergency with first I'll do through the ATLS protocol, and we'll secure the airway and we'll shift to other. There is a depressed fracture also in the frontal lobe, and we will rule out the intra skull head injury, and after that we can taken to OT and do the intermaxillary fixation for the proper dental occlusion, and we'll patient is very sick, we'll do the intermaxillary fixation and leave it. We'll do it later, but if patient is stable, we can proceed with the maxillary fracture fixations. one plate over the infraorbital rim, other plates over the maxilla to fix the fractures, and will secure the airways.
Open for discussion, panelists.
How will you classify this fracture?
Lifo to 1, Lifo 2, Lifo 3.
What is this?
This is Lifo 2, sir. It's a pyramidal shaped fracture.
What is Lifo 4?
Lifo 4. Lifo 4 combination.
Does this patient have any frontal bone fracture?
It's a frontal bone fracture is there, sir.
Does that change the classification?
Not sure, sir. Sorry, sir.
Do you expect anything important in this patient? You see, there is a fracture which is running to the base of the nose. Okay, that is the nasofrontal disjunction. Frontal disjunction, right? So what do you expect? What important things are you expecting in this patient? What precaution are you going to take when you are planning for a surgery?
CSF rhinorrhea, CSF leak can be there. Ethmoid bone also involved.
So what should you take care during the surgery? What should be the intubation thing? How will you intubate the patient?
It should be
intubation,
submental intubation.
Submental intubation.
Okay. Tracheostomy. Would you think of tracheostomy?
Tracheostomy. Sir, tracheostomy can be done, sir. Submental tracheostomy and intubation.
Okay. Yeah, any other questions, sir?
Is there any involvement of nasoethmoidal region?
Yes, sir. Nasoethmoidal region is involvement is there, sir.
How you are going to manage that? There will be depression.
No. Nasoethmoidal. We should take care of
that portion will be depressed, na? So, to go inside. You have to take it out and fix it. And you have to contact your neurosurgeon also, because
yes, sir.
depressed frontal bone and they are in that region. There may be a CSF leak.
Yes, sir. Yes, sir.
You have to be careful.
Yes, sir.
So how will you approach these fractures? What will be the approach? Incision.
Incisions for the maxillary region fracture, we can fix it with the infraorbital incision, sir, and the infraorbital region, and also vestibular, maxillary vestibular, upper gingival sulcus also we can approach, and we can do the incision in the coronal incision, and also we can.
No, you can do many things. What are you going to do in this patient? How are you going to fix the nasofrontal junction? Is there any laceration? The history part is important in this patient. This is a quarter.
If there is any laceration, we'll do the same laceration. We'll open.
There is no laceration.
Yeah, so you have to be prepared for a bicoronal incision.
Bicoronal incision.
Correct.
Yes, sir.
The other thing is what do you expect in the post-operative? You know, what complication do you expect in post-operative?
Patient may have a severe infection, cerebral infection can occur.
Okay.
We have to give him antibiotics and airway to monitor the airway monitoring, and CSF leak also should be monitored, sir.
There is fracture on both the orbital floor area. How are you going to take care?
Then ophthalmic evaluation also to be done, and continuous intraocular pressure should be measured. There is any, we have to release the pressure, sir.
So what is the complication that you expect if you have a bilateral infraorbital floor fracture?
Orbital.
You warn the patient about something.
Diplopia and
Correct. So will you do anything for the floor also?
there's a floor infraorbital rim must be fixed with the plates.
So floor you won't be doing anything. You know why the diplopia? Why is there a diplopia after doing everything, all the fixation done? Why do these patients have diplopia? Can have diplopia, not in all patients.
The entrapment of the muscle, sir. Inferior rectus muscle.
And that can be one.
Edema can.
The eyeball may, because the floor is gone, the eyeball may get displaced downwards. Okay, and that may be the cause of diplopia. So you need to reconstruct the floor.
Herniation of orbital fat.
So you need to reconstruct the floor as well. You put either a titanium mesh or a bone graft.
Okay.
So beforehand, you need to know how much the fracture is. If it's a big defect, then you need to put a titanium mesh to take care of that diplopia. Okay.
Okay, sir.
That is the common site of the orbital floor defect.
Common
Site of orbital floor defect. Where do you expect commonly?
Zygoma and intraorbital rim.
The floor and medial
Floor and
wall.
lateral part of the
medial wall.
Okay, ma'am.
JK sir, Srikanth sir, any questions? 2 more minutes are there.
Medial wall.
What are the type of implants?
Implants, Medpor implants.
Plate.
Plate is arrested.
Plate.
So we'll use titanium plate and resorbable plates. Bioresorbable plates are available, sir. Depends upon the availability. We can.
What will you do for the depressed frontal bone?
We can use the acrylic. One thing we can do acrylic implant later stage. And second, we can do autologous fat grafting to camouflage the effect, depression. 2 things can be done. And stainless titanium plates also available, fillets and Medpor implants are available, sir. We can use any
but
of
if
them.
neurosurgeon is available with you, can you?
Then we can elevate and fix it with a low profile.
So that's what I have asked now, whether neurosurgeon you is concerned or not.
Yes, sir.
You are going to open with the bicoronal approach, frontal approach.
What is an osteo-integrated prosthesis for floor of the orbit?
Integrate.
Yes,
sir.
Who is Leaford? From which company? Which country belongs? France? France, Italy?
Time is over.
Don't know.
France.
Okay, fine. Right.
Measures.
What is this?
It's a stainless steel skin graft measure, sir, with the parts describing on it's a plate for keeping the mesh. One is the marking, one is the
It's a carrier. One
Carrier.
is the
carrier.
And 2 is the stainless steel mesh, right? And 3 is the roller.
To do the measure roller is there, and this is used mainly for expanding the mesh grafts, the meshes 1:1, 1:2, 1:3 ratio, and it will be helpful in the covering the large defects, when the donor area is very small. We can expand the graft and helping. Mostly we'll do in the post burns and post traumatic raw areas. Can do. And
availability of the donor.
what are the uses? Yes, sir. It describes the name based parts and uses. And,
what is one?
one is the carrier. Carrier, sir. So that is a plastic fiber plastic carrier. So over that skin graft will be kept, harvested skin graft, and will be kept in the mesh, feed it into the mesher, sir. Two is the mesher box, and 3 is the roller, sir, with the sharp multiple blades will be there, and will helps in. We can change it according to
what are the uses of meshing?
Meshing, it helps you in the preventing the seroma to occur and increase the graft uptake, and also helps in the increase the surface area of the skin graft available. Yes, sir.
What will be the disadvantages of meshing? Meshing more.
Scarring will be a Swiss cheese pattern of scarring at the time of healing, sir. And scarring will be like scale like snake-like skins, and aesthetically looking.
If this instrument is not available, how will you use the mesh? How will you do the meshing?
We'll do the meshing by the hand, sir. Hand meshing we can do in the ratio of 1:1.
No, you cannot do meshing with the hand. You can have to use the number 11 blade.
Number 11 blade will use and do with hand. Yes, sir. Number 11 will turn the graft
Now,
to
which are the parts? Yeah, now which are the parts in this apparatus that are moving?
Ratchets are moving.
That roller kind of thing, that handle will be, we'll push the handle down, sir, above, push the handle down. And that central rolling part will be there, sir. That will be moving, sir. And the carrier also will move out to someone else. The carrier also will be carrier on the opposite side.
Yes. So what does the roller do? It rolls, whereas the carrier advances. Now, how will you decide what is going to be your meshing ratio?
It depends upon the requirement of the raw area to be covered.
No. Part of this instrument decides what is the ratio mesh you will get.
The roller blade, sir. Roller blade.
Is it roller blade?
Roller blade, and there is some knob adjustments will be there on the sides. Roller blade.
Have you used it?
Yes.
We have a little advanced.
Okay, now you said you want to use this to get an expanded graft, isn't it?
Yes, sir. Yes, sir.
Yeah. Supposing the raw area is very large, even by meshing, you cannot get an expanded graft. What is the other technique that you can use?
Pixel grafting can be done. And
anything else? What did you say?
Pixel grafting, stamp graft, pixel grafting, meek grafting.
What is meek grafting?
It is you have to make a small harvest of graft, and you have to, that is a special disc kind of thing will be, sir. You have to put that skin graft into that, and then you have to press in that hydraulic kind of pressing machine. Pressing machine. And
there's some voice system.
Some voice. That meek graft will break the
meek skin
and it will kept on the silicon layer and will expand it, sir. From the 4 angles it will expand and will put the graft over.
Yes, correct. So meek skin grafting can be done for very large raw areas, isn't it?
Yes, sir.
Which is easier to mesh, thick graft or a thin graft?
Thin. Not so thin also will be difficult to measure. It will be should be an intermediate thickness, sir. Not so thin and not so thick, sir. Should not have.
What will happen with a very thin graft? What will happen if
When
you use a very
thin
graft for
it will
meshing?
tear off, sir. Very thick graft, if you mesh na, it won't expand as much as expected.
Yes, correct. Correct.
Noise disturbance.
Now,
Noise disturbance.
Any device is there when near to your computer?
No,
Please
no,
answer.
sir. We don't have any device.
Okay, okay. Answer the question.
Sir, could you just repeat the question?
what was the question? Even I have forgotten the question. What was the question?
How many times you can expand the skin with the measure? How many times you can expand with the make micrograft? Maximum.
1:16 ratio we can expand. 9:16 ratio.
1:6 with the measure, 1:10 with the make micrograft.
Okay.
And the carrier is the one which decides what is the ratio, how many times, because the carrier has to be changed. What is the advancement in the measure now?
Electronic measures are available.
No. Without carrier.
Carrier.
There is no need for carrier now. So what depending on the ratio of the expansion you want, you have to take the different measures.
Okay. Okay.
So 1 more minute is there for measure.
What is a cobblestone appearance?
It will be seen in the field area of the mesh graft. What is the raw area? Because of the multiple holes.
Because
of the multiple holes in meshing rate.
So which is better for taking of graft? It is a meshing graft or it is split?
Which is better for taking of graft? It is a meshing graft or it is split taking?
Sir, could you repeat the question? It's breaking in between.
Which is better for take off of the graft? It is a split thickness skin graft or a meshing graft?
Take up of the graft depends upon the meshing. It depends upon the thickness of the graft and the quality of the thickness of the graft and the quality of the
Time is over.
Time is over. It is the showing the upper limb, the raw area. It's exposed to tibial bone. Raw area. It's exposed to tibial bone with the biplanar with the external fixator. The biplanar foot rope present in the lower limb. Foot rope present in the lower limb. Something is breaking. No, sir. Oh, sir, we'll plan this the upper limb defect with the exposed bone of
What
the
investigations you will?
what we'll do investigation. The patient will do the X-ray of the lower limb, and we can do the CT versus the CT bone, and also with the vessels angiography to assess the condition of the vessels and to rule out osteomyelitis. And we'll take the bone, exposed bone, we'll take a bone biopsy also, and to rule out osteomyelitis, and we'll plan further. We need to assess, rule out osteomyelitis and assess the vascularity. There is traumatic. What is your option of reconstruction? Option of reconstruction will depends upon the patient condition, surgeon's factors, and institutional factors, and availability of the facility in our hospital. And also we discuss with the patient before the surgery. We'll discuss the options available, and comorbid condition of the patients also to be assessed. Depends upon that, our options will be like based upon the staged reconstruction. Will improve the nutrition of the patient, and followed by reconstruction. I will like to do the anterolateral thigh flap for this patient, free anterolateral thigh flap to cover the raw area for this patient, because the surrounding looks like nearby regions also everything is scarred and injured, so local flap won't be a feasible option in this case. We like to do the I will do the anterolateral thigh free flaps.
Which
Any
vessel
local
will you
option is
use?
available?
Sir?
Any local option? For upper one third of the upper one third.
Medial gastrocnemius flap can be assessed, sir. We can try, but in that region X-fix is there, and posterior region of the skin also we are not sure about that. Depends on the picture, can tell it's pre-flap reconstruction. Local flap will be able to do, medial gastrocnemius flap can be taken.
Any other local options you can think of?
Soleus won't reach that much.
Anything in the
sural artery flap, not reverse sural, from the medial sural artery based sural artery flap can be bring it to the place.
Any flap from the thigh?
We can do reverse ALT flap also we can try, sir. But in that region, that around the skin also, knee region, there is injury is there. But in that case, the perforators of the reverse ALT will be affected, sir. That won't be also. That will be a precarious option.
I think Karthikeyan sir has already asked, which vessel are you going to use for this anastomosis of your, if suppose you are doing a free flap?
We'll do the branches of the popliteal artery, only median sural vessel and lateral sural vessels we can use and do the anastomosis, sir.
That you will get easily.
If not, but the vessels we are not getting, we can directly anastomosis to the main arsal, main vein, sir. Main popliteal artery, main.
You think you'll get these vessels very easily? With this scarring and all those things, you think it is easy to get the vessels over here?
In this region, posterior region, sir, we should put the portion in the lateral position, and we'll expose the vessels in the popliteal region, sir. And we'll take the control of the popliteal artery and the popliteal vein, and we'll identify the sural artery, and if his branches, any branches available from the popliteal artery and popliteal vein, we can anastomosis the branches. If it is not able to identify because of any injury, we can directly anastomosis to the main vessels. Here we won't get it, sir. We have to put the.
What is the problem in anastomosing to the main? Yeah, what is the problem in anastomosing to the main popliteal artery?
That we have to take the control ischemia chance or thrombosis if occurs, there is a chance of distal blood supply also will affect. So we have to close monitoring of the patient, and we also apparenize the patient to prevent the thrombosis at the anastomotic side, sir.
Now here you are doing a very different procedure of opening in the popliteal region. Who has described this technique?
Describe the
technique of opening in the popliteal region and exposing the vessels and using a vessel for anastomosis. Who described this approach?
Starts with G.
G.
Godina's approach.
Yes. Godina approach, Marcos Godina approach.
Yes, sir.
And he did a wonderful study about reconstruction using the latissimus dorsi muscle flap. Okay. He found, we have also seen that there's a lot of necrosis of the muscles that occur when you use the veins in the middle third or the distal third of the leg. Okay. This is because the latissimus dorsi is a very high metabolic flow. There is a lot of blood flow and the venous return is very high. As you know, how many veins are there in the thoracodorsal vessels? How many veins do you get?
Oh, 2 veins will get, sir. That is LD flap will always 2 veins will get, sir. 1 artery and 2 veins.
Have you seen the LD flap?
Oh, that.
One vein will be
here,
small and
No. See, here you said you want to go to the popliteal region. That means you have to take the muscle and you have to take a long length of the vessel.
long length of the pedicle, sir. If the pedicle
Yes.
length is not there, we have to do the vein graft. Take the vein graft.
No. See, long length, usually you have only one big vein in the latissimus dorsi. Okay. Now the veins in the upper limb are very thin walled, whereas the veins in the lower limb are thick walled because they have to withstand the pressure of gravity. Okay.
Yes, sir.
They found that when you anastomosed the latissimus dorsi vein to these veins, there was a lot of venous insufficiency. This vein, the vein in the leg is not able to accommodate the blood, increased flow. That is why Marcos Godina said, go to the popliteal region where you get bigger veins. So that is Marcos Godina approach. Now, supposing the question is, if it is only soft tissue loss, you said you can do a gastrocnemius muscle flap. Supposing the question is, if there is soft tissue and loss, how would you manage?
Sir, we have to convert the frame into the Elizaro frame, and we can do the bone transport, sir. Other thing we can do is we can do the a different piece very small. We can do the alveolar bone graft or a free bone graft.
Alveolar bone graft. What is that?
They're not, sir. That's that fibula. From fibula, we can take small groove and fill the space.
No. First thing you said, you said we can do a bone transport. We cannot do a bone transport. We are plastic surgeons.
Okay, sir. We can ask the orthopedic soon to convert the X-Fix into the Elizaro and we'll do the bone.
The question here is, what are your options for reconstruction?
I will change into Elizaro and do the bone transport.
So you'll send it to the orthopedic surgeon. That is your reconstruction management option. The question is, what is your option for reconstruction when there is both soft tissue and bone loss? Can you reconstruct both the soft tissue loss and the bone loss together?
Prefibula flap.
Yes. So the question you have to ask, what is going to be, you're going to plan it according to what is the length of bone loss? What is the amount of bone loss?
Yes, sir.
Small bone loss less than 4 centimeters, you will refer it to your colleague. You give the skin cover. Now, you said your first management was ALT flap, isn't it? Free ALT flap.
Yes, sir.
Yeah. After doing a free ALT flap, can you send it to your orthopedic colleague for bone management of the gap, 4 centimeters?
Oh, sir, not immediately. We can have to send it later only.
Okay, after the flap.
Before surgery, we can change into Elizaro and take up for surgery, sir. Otherwise, we have to finish the surgery and we have to send it once the flap settles well. There's no complications of flap. We can send it after 1 month for a bone Elizaro placement.
Supposing there is a bone gap of 6 centimeters there and a skin loss, can you think of any flap cover now?
6 centimeter with the skin loss, free fibula bone graft can free fibula can be done.
Free fibula, please be specific in what you have.
Free fibula, osteomyocutaneous flaps.
Why osteomyocutaneous flap? What muscle do you want there?
We'll take along with the FHL, sir. FHL muscle will take along with that bone, sir.
Why do you want FHL?
To help, it will cover the bone, sir. It will and also helps in covering the surrounding tissues beneath the muscle. You can cover the bone.
Okay, so you have the option of a free fibular, osteocutaneous, or myocutaneous flap, isn't it?
Yes, sir.
Right.
To interrupt, time.
Time is over, sir.
Yes.
Okay, go to next one.
Counseling. Tell something here. Diagnosis is group 2. According to Nagpur classification, it's a group 2 cleft palate. Will counsel the patient. The patient child is of around 3 to 4 years. 3 years old. It looks like. So we'll counsel the parents regarding what is the requirement for the child, and we'll tell the parents about the need of the surgery and about the what is the speech therapy needed after surgery, and what are the diet should be advised after surgery. We should all counseling should be pre-op counseling will be given, and what is the pros and cons of surgery, and what is the pros and cons of not doing the surgery should also be explained, and management plan. I'll do the Von Langenbach palatoplasty, Bardax 2 flap palatoplasty, and along with the intravelar palatoplasty, and advantages of various procedures. Various procedure means advantages. Various procedures are Von Langenbach, Bardax palatoplasty, and Vio-Wardnick-Kilner pushback palatoplasty, and IVBP are there. Advantages are it helps in the closure of the wound in the central midline, and then will the dissection of the flap in the submucoperiosteal plane. The Bardax will have the 2 flap. All the anterior connection will be cut. Only it is based upon the greater palatine vessels. Von Langenbach will have only the lateral incision. The anterior connection will be intact, so it will act as a bipedical flap and will suturing the midline. In this disadvantages, sometimes if the flaps will not be closed in the closure in the midline. So at the time we can need the extra vomerine flap from the nasal mucosa for the closure in the center, and we'll need a dissection. And in the soft palate region, the tensor palapalatine, levator palapalatine muscles to be approximated closure by dissecting the levator palapalatine muscle from the pterygoid hamulus on the both sides, and bring the muscular dissection, and we'll close in the palatine muscles in the midline, and we have to do the repair in the 3 layers. One is the nasal mucosal layer, muscular layer, and the oral mucosal layer in the soft palate, and the anterior hot palate region we have to do stitch of the mucoperiosteal flap in the midlines. Sir?
Can I ask a question on behalf of the parents? Okay. Now, you are saying that you want to operate on my child, this child. After this surgery, will my daughter be able to speak normally?
No, sir. First, we have to do the pre-op speech evaluation, and we have to assess what are the difficulties the child is facing and what they're expecting from the mother. And we can counsel pre-op. After the surgery, it won't immediately improve. We have to give the speech therapy, and continuous speech evaluation should be given, sir, to the child and parents also, to teach the child in the home regarding the speech therapy, and it will improve in the gradual process.
Doctor, you have said that there is a gap in the palate and you said you're going to repair it. After repairing it, why should the child's speech not become normal? Why do you think it will not become normal?
By the brain plasticity, sir.
Something else. Don't go into brain plasticity and confuse me. Tell me something that is more simple. What causes normal speech?
Pharyngeal insufficiency, sir, as already said.
Yeah. So what can you do? Why do you have to explain that to the parents, isn't it? You have to
do the nasoendoscopy, and that will be after.
The question I'm asking is, as a parent, I'm going to ask you, the parents will ask these questions. Why will my daughter's speech not become normal after closing this gap?
Closure of the door, posterior,
yes.
Posterior pharynx is not adequate.
Why is it not adequate?
Because the palate is short, sir, compared.
Correct. It's pulled up, isn't it? So what you're doing is, what your palatoplasty is trying to bring it back. So that is why it's called a pushback palatoplasty, isn't it?
Yes, sir.
But still, it may not be enough. So that is when you have talked about the valoparatine insufficiency. Supposing you said that this girl's speech may not be normal. Suppose I come back after 1 year and say, look, after therapy, speech therapy, it has not improved. Can you do something?
Pharyngeal flap can be done, sir, to increase the closure of that pharynx, decrease the pharyngeal flap can be done, and we can lengthen the palate length by Murari Mukherjee flap can lengthen it, and we can use better lengthening procedures with the flap cover or pharyngoplasty can be done.
Yes, so you want to do some procedure to make the speech normal, even if I come back after 1 year. Now, supposing this girl grows up to 16 years of age, will there be any deformity that is seen outside? Will she look normal, or will there be some difference?
Maxillary growth will be affected, sir. It will be some retracted maxilla can occur. Dentalveolar.
Why is that going to be affected? You have sutured the bone, you have sutured the gap, you have closed the gap. Why should there be a
normal growth pattern is affected, sir. In the growing child, it will pull the muscles, and the pulling will prevent the scarring will prevent the expansion of the maxilla.
Yes. So now you are telling me that at 16 years of age, this child will have a maxillary retrusion. Can you do something now to prevent that maxillary retrusion from occurring?
Tension-free repair has to be.
Tension-free repair has to be done. You have to see the palate now. If it is contracted, you have to expand it, isn't it? You have to expand it now and then do the repair. If you expand it, the gap will become bigger.
Yes, sir.
So if you expand it, the gap becomes bigger. You have to reconstruct that gap, right? So then the chance of maxillary retrusion becomes less. That's all. It doesn't completely obviate the problem. And will my child's nose be normal, or will it be abnormal when she reaches 16 years of age?
Nose will be In this child, it will be normal.
Why do you think it will be normal?
Because lip is not involved, sir, and it's only involving the hard palate, posterior part of the hard palate and the soft palate, sir.
Yes. Okay. Okay. Good.
Sir, I think time.
Yeah. Okay.
Just documentation. How will you document all the aspects? How will you document all the aspects related to this injury? Sir, we will document when the patient receives an emergency. We'll document the patient in the emergency room. I'll ask the patient to do what are the movements can be done. And video documentation of the movements and the documentation of the injuries. And we have to do the sensory the median nerve region and ulnar nerve region and also in the radial nerve. So we'll see document the sensation of the hand, the movements of the thumb, which is also important because thumb is in the adducted position. And the hand cascade is lost. So video documentation, X-ray of the hand and the ultrasound Doppler to assess the vessels, and sensory examination and clinical examination, and MLC, medical legal documentation to be done. And
yeah, supposing you're going to write down the findings in this particular injury page, in this hand,
yes,
just
sir.
All the points you'll mention.
We'll mention that zone of flexor is 1, 2, zone 5, 3, zone 5, zone 5, flexor tendon, flexor tendon injury over the flexor aspect, and the thumb is extensor T4, T3 level of the thumb extensor injury, and we'll mention, sir, and the normal.
You said zone 5 injury. To which tendons do you think are injured?
Flexor tendons of the hands. One TS, FDP, FPL can also be injured, sir.
No. You're not. You're being very vague. If you say, you can't say flexor tendons of the hand. You should say flexor tendons. Which flexor tendons?
Middle FCR as FDS of the index and middle fingers.
FDS of the middle and index fingers. Okay.
FDS,
FDP also the index and the middle.
Okay. Then
extend the thumb. That is extension EPL could be lost in the thumb, sir. Extension is some abductor thing, is there? And
yes.
And there is a claw hand, ulnar claw hand could be ulnar nerve injury kind of. That ulnar claw hand won't appear immediate trauma. That is.
Wait, stop. What? Who said that? Ulnar claw hand will not appear immediately. Who said that? How long
can appear? Can appear, sir.
No. Please get this sorted out now. Ulnar claw will appear after how many days or how many years? No, there are 85 people watching. They must not go home with the wrong idea. Okay?
Yes, sir.
Ulnar claw will be seen immediately. Okay?
Immediately. And the ulnar claw.
Yes. Okay. Right. So that is a point to be taken. Right. Then what else can you note? What is the position of the thumb?
Thumb is adducted, sir. Adducted and.
So do you think something could be wrong with the thumb? Can you see a swelling there of the arm?
Thinner injuries, thinner muscle injuries.
Yes, muscle injury is also there. So this thumb is adducted. So what do you think is the cause for the adduction of the thumb?
Abduction is lost, sir, and extension is also lost.
Yeah. So what do you think is the cause for loss of abduction?
One is abduction. Abductor pollicis brevis can also be injured. EPL can also be injured.
Okay. Supposing the muscles are not injured. What can cause
Carpial fracture, metacarpal fracture can also be there.
Yes, could be there. Any other nerve injury can cause this condition?
Median nerve injury can.
Median nerve can also cause this position, right? Okay. Is there any other question in this slide? I think it's just documentation of the different aspects of the injury, right? Okay.
So no other questions, sir. That's it.
Yeah.
Do you have a video recording of these movements?
No, sir. This will be the photo.
Not the only photo. Okay.
Yes.
Yeah. Any other questions from the other people, other panelists, sir?
So the question has to be related only to the documentation part, not to other things, right?
Yes, yes.
That's okay. It's fine then.
There is a time of 2 minutes. If you want, you can ask anything.
No, just in these patients, if you ask the patient to do some activity, probably they will not be able to because of some pain. They won't be doing such activity, right?
Yes,
so, so on table there is one way to know the tendon what are the tendon injuries. So what is that passive test that you can do to assess whether what tendon may be injured? Is there any passive test that you can do? So active test means you ask the patient to do the activities and you whatever is missing, you reduce from that with this action is moving. Is there any passive test? Yeah.
Yes, sir. We can assess the
forearm and we can see.
We can assess the joints movements. Any the flexor tendon is injured. If we move, we can't feel any resistance in the finger, sir. On the injured side.
We'll press on the
forearm,
and we can see the movement.
It's called the squeeze test, where you squeeze on the forearm muscles. Okay, and then when you squeeze, all the tendons which are intact will have movements, and those which are not intact will remain like that. So that is one of the tests which you can do to diagnose the injured structures. What is the incisions that you are going to give in this patient for exploration?
Incision will connect this forearm incision. Will connect both incision and will extend in the extension. One extension on the end of the incision on the radial side, another extension on the ulnar side, sir, proximally. So it will explore the two flaps will be raised, one on the proximal side, one on the distal side, to explore the tendons.
And you won't be exploring the thenar part. There is a cut. See, this is a glass cut injury, if I'm not wrong. Is it glass cut injury? The diagnosis.
Yeah.
So
thenar part will be approached.
Yes, when there is a glass cut injury, wherever you have a cut, I think you should be exploring that part. There may be injury to the muscle of thenar muscles as well. There is a cut over there. You have to explore the thumb as well, where there is a laceration. There can be a tendon injury there also. So these are all the sites that you need to explore to repair this patient, the injuries, right?
Yes, sir.
Yeah.
Can I have a question?
Yes, sir. You can ask.
Okay. As a medical legal expert, what documentation will make regarding the type, nature, and the time of injury? Time, nature, and type of injury. And if you are asked more, it is homicidal or accidental or it is suicidal.
Yes, sir.
How do you address these three things?
Time, homicidal.
You have to give a gross opinion, your medical legal opinion. You are seeing first time as a plastic surgeon.
Sir, depends upon the which hand is injured.
No, no, no. You have to give the timing. As in, when you write the injury report, as a primary surgeon, if you have seen it, you have to give a timing of this is the time, at least 2 to 4 hours or 5 to 6 hours, whatever timing you have to give. Then type, it is an incise cord lacerated. That also you have to give.
Okay, sir. Okay.
Then nature of injury or etiology of the injury, or it is a homicidal or a suicidal or accidental. This will be a medical legal report. It will go to the court of law and you will be called for giving verbally evidence and
As well as
your documentation. Okay?
Okay, sir. Okay, sir.
it's a simple or grievous injury also you have to
Yeah, yeah,
mention.
right, right.
And
Right.
X-ray should be compulsory. Okay.
Yes, sir. Yes.
Yes.
Yes, ma'am.
So these are the things you have to make in a documentation apart from the clinical findings.
Ma'am,
So
we can.
the all sessions are over. There are no questions in the chat box. So the preliminary contest of team 2 is over. So now we have come to the very nice presentation and very good answering. I congratulate the team 2, Jipmat PGs. Panelist session, GK sir, would you like to share your screen?
I think I've already given the video to the organizers to play.
Okay, okay.
In 1 minute.
Rohit.
1 minute, ma'am. I
Yeah,
think
yeah.
That's the presentation.
Yeah, that's
Sir, always presentation will have audio.
no. This time it's not.
No,
audio.
sir. Not recorded.
Yeah.
Yes, sir.
Now, as far as this session is gone, I think the 2 candidates have answered very well. Team 2 from Jipmat. I think we must give them a good hand because they have answered all the questions from all the expert panel, and then they have also answered the questions from their counterparts also. That is very difficult because those people are out to gun. At least we are asking quite benignly. They are asking quite malignantly. The colleagues. That's good.
Yes, sir.
That's
because they will be getting marks, no, sir.
Yeah, in this aspect, I want to tell you that one, the questions from the colleagues, that is from the other teams, should always be in regard to the presentation, the case under discussion, because you can study up some rare phenomenon or syndrome and ask that question. That should not be there. It should be with regard to the problem that has been discussed, one. Secondly, I feel that those who have not come, the teams that have not attended, those extra marks should be given to the answering team, team 2 today.
Yes, sir. That is, judges are considering that.
Yeah.
So they are team of judges. They are continuously watching our session. So there are 10 components, and each component has got fixed marks, sir. And they are giving, as you said, that is considered already, sir.
Okay, thank you, madam. Now, I just wanted to give a small presentation regarding preparation for super specialty exam. The question is, can you go to the next slide? Yeah. Why me? Maybe I am a good person to talk about this because I have seen both sides. I have failed in my first attempt and I got through in my second attempt. So I can analyze what went wrong in the first attempt and what went right in the second attempt. Can you go to the next slide? Yeah. The important thing is, it's 2 things. One, you have to think about the written examination, and the second about the oral examination or the clinicals as it's called. Written examination, the first thing is you have to prepare a schedule. You have to have time. You have to set up time. You have to block the time for, at the same time, it must not be too rigid schedule. I've seen people making schedules so tight, no, that you can't even breathe. You don't even have time for breathing. It should not be like that. You should give time for obligations, give bio breaks, schedule fun also in between, go to a movie, whatever. And then you have to have your study time. Only then it will be a balanced time. You can't have everything or only proteins or only carbohydrates. You should have a mix of everything. Only then this schedule will work. Next slide. The next point is discuss after learning. The first time when I wrote the exam, I had taken 1 month leave. I sat at home and studied. That did not work. Whereas the second time I wrote my exam, I was not given 1 month leave. I was asked to sit in the hospital and prepare along with my co-PGs. So that was wonderful because you discuss. It has been proved that after learning, you will have 100% of information immediately. But after 1 hour, it will come down to 44%. So how do we increase this? How do we increase this? Is different types. I'll be talking about that next. Stress management. People nowadays go through a lot of stress, because there are a lot of things. You have to see your Insta, you have to see your WhatsApp, you have to see the reels and all that. And in spite of all this, you have to study. And you also have a social life, which is very important. So with all these are not taking away from your stress. That is your reels, your WhatsApp are not taking away. All that takes away from your stress is meditation and exercise. Most important things. Next. Yeah. Now, when you come to clinicals, there are two things, preparation and next is the performance in the clinical examination. Let us see what goes into preparation. Next slide. Now, I'll tell you one very important secret that has not been known to anybody so long. To prepare for a good clinical examination, you have to see cases. This is a top secret that I'm telling you today. You have to see cases. Then, after seeing the cases, you have to discuss. I already told you that you have to discuss. Now, today's session in PLASTIQUEST was an eye-opener because this discussion was wonderful. This discussion is excellent because to memorize quickly, you have to have repetitions after 15 minutes or 8 hours or 24 hours you have to do. And to memorize for a long time, you have to have, this is called recruitment. Okay, how do we get this recruitment? You have to talk. Can I go to the next slide? You have to discuss with colleagues. You can discuss with your own friends. Now, today's questions that the colleagues were asking, co-PGs were asking them, was very interesting actually, because they read up some aspect and they ask the question. And these guys who are batting, they have to answer it. That is one type of learning. You have to discuss with your colleague, discuss with your teachers. Discussion is the most important thing. Please remember, in the examination, when you are asked a question by the examiner, it will be an absolutely simple question. The person who is sitting on the side, who is watching, will wonder, oh my God, such a simple question. Why is he not answering? Actually, you know what happens. It will be a simple question and the candidate knows the answer. But when you are under stress, the only answers that come out are those on the top of your brain. And how do you keep all the important information on the top of your brain? By discussion, and that is called recruitment. The information keeps coming up and it sits on the top. So when the question is asked, immediately the answer will go, right? So only discussion will bring about this. You can talk with your teachers, you can talk with your juniors. The senior PG can talk to the juniors. The senior PG can discuss about flexor tendon reconstruction with the house surgeon who is posted in the unit. It is of no use to the house surgeon. It is of great use to the person who is discussing it, who is teaching it to the house surgeon, right? Or even the staff nurse. If you don't get anybody in your, you're not able to catch anyone. Catch the staff nurse who's assisting you in a skin suturing. Tell her about how to reconstruct the flexor tendon. They are never going to say, I know I'm not interested. They listen. So you are getting benefited. Next slide. Performance. In the examination, one thing I've noted is students, in a enthusiastic fire, they immediately answer the question. Please take time. You are not given marks for answering quickly. You are given marks for the accuracy of the answer. So think before you speak. You are allowed to take a few seconds to think What is the question? Usually the examiners are not going to come for your exam after preparation. They come just like that and they'll ask you very simple questions. All you need to do, the problem is we think that they're going to ask complicated questions. It is not so. So all you have to do is think what they are asking and answer. Next slide. And when you make a statement, try to defend it. Don't immediately jump across the floor and go to say, yes, what you're saying is right. Try to defend, because you are going to think an answer. So when you are making an informed answer, you have to try to defend it. But if you find that you're absolutely wrong, next slide. Of course, you're going to have other procedures. Options must be ready. And next, you're going to demonstrate three things. Competence, next slide, next, safety and ethics. When you're going to talk about previous slide. Yeah. Now, when you're talking about competence, when I'm asked a flap cover, for instance, today the question was, what flap will you do for the upper third defect in the leg, isn't it? So they talked about the anterolateral thigh flap. So now we need to, if they have seen the flap, they have assisted in the flap, they'll be able to confidently answer it. So that talks about their competence. Second is safety. When you're making a plan, it should be safe for the patient. That is very important. You can't say some rare procedure, I'm going to do a parascapular flap. If you're going to say that, it is not good, because you have not done it and you are compromising the safety of the patient. The third is ethics, must be followed when you are answering in the examination. And next, the final slide. When you make mistakes, I told you, when you make a gaffe, when you make a mistake, don't try to cover it up. The examiners can see through it. So just accept it gracefully and keep going with the flow. You will definitely succeed in your exams. All the best. Thank you.
Thank you, sir. Wonderful presentation and good guidance for the PGs. PGs, anybody wants to ask any questions or clarify your doubts? Can come forward.
Dr. Lakshmi, I would like to add something. Because sir, very well presented and very well guided, sir. Your always presentation are always good. But I will say a few words, few things about the new PG guidelines which have come regarding examination. They have said, the NMC has said that there will be one long case and 2 short cases and 4 theory papers. And out of 4 theory papers, they are saying that you have to pass in each paper will be of 100 marks and you have to score 200 marks and at least 40% marks in each paper. So if a candidate scores in less than 40% in any of the theory, he fails in the theory. One. Then they have added one thing. They have said 1 long case, 2 short cases, then OSCE type of things, the practical, then radiology, then histology, then the pathology, and then instruments. And they have also said there will be a viva on the thesis that is made compulsory. 5% of the practical examination has to be viva, which of the thesis and thesis or dissertation that has to be conducted by external examiner, and 20 marks will be of those thesis work. So these are the additions in the for the institutions which are under NMC. This may not be applicable to the national board. This may not be applicable to the AIMS or JIPMER or PGI Chandigarh. But this is applicable to the NMC guided institutes.
I think add to that, there will be 4 cases on ward rounds.
No, that is, they have not commented anything on the ward rounds. They have commented on the OSCE. They have said 1 long case, 2 short cases, and OSCE-like questions.
One round marking to be done, that is also been specified by 2023 NMC regulation.
Ward rounds are there.
Yeah.
Then they have said, and then the as sir has
That means
said,
post-op cases. What round means a mean post-op cases.
yes,
How you manage
yes,
that? That is the point.
yes, yes. Then you get long cases. You should prepare the list of long cases. What tentative long cases you get: oral malignancy, leg cases, or PVC neck. These are the important 3 cases which you get. And all the PGs should rehearse among themselves. Exam going batch should talk among themselves and discuss the cases in the evening after the rounds. And they should, as sir has said, they should keep talking. When you talk and you come out, you say, then your knowledge goes at spinal level. As in the exams, you are at spinal level, your brain stops working. Whatever you have seen, and also always answer whatever you have seen in the 3 years training. Don't jump into the books or internet knowledge. Just say whatever you have seen or whatever you read in your standard textbooks. So that will help you. And your internal examiners are there to help you when you say something which you have seen. And the external class, the internal will say, yes, we do that. So always say whatever you have seen in 3 years training, and don't be afraid, and discuss whatever DK sir has said as usual. Thank you.
Thank you, sir. We have a video presentation by Brajesh sir, Brajesh sir. So if you allow me, can I run the video, sir?
Yeah, sure. Go ahead.
Okay, sir. Thank you.
So this video has got a voiceover, so I think everything is well explained. If there is any question, we can take it in the end of the presentation. Hello everyone, I am Dr. Vimalendu Brajesh. The video has stopped. There is no audio. Organizers, please note there is no audio.
Sir, is there any issue with the audio?
Yeah, this video is with the audio. There is a voiceover.
You are not getting audio, sir?
No, we are not getting the.
1 minute, sir. Now, is the audio visible?
Hello everyone, I am Dr. Vimalendu Brajesh, and today through this video. It's okay now.
Now you are getting the audio, sir?
Correct. Yes, it's all fine.
Okay, fine.
I'm going to navigate you through the different key and important steps of the exploration of brachial plexus. So before we start with the surgical steps, I would give you a brief overview of the anatomy of the brachial plexus. Good evening. I am Dr. Vimalendu Brajesh, and in this video, I am going to give you a brief overview about the anatomy of brachial plexus. We'll try to make it as simple as possible. As you know, the brachial plexus consists of 2 terms. One is the brachial and the other is plexus. And the word brachial comes from brachium, which means the arm. And plexus is a complex of nerves. So basically, it's a complex interaction of different nerves which actually go and supply the upper limb. So let us look at the 3D model of this brachial plexus. If you see, the initial part of the brachial plexus is quite simple. It arises from the spinal cord and specifically from the root C5, C6, C7, 8, and D1. All these 5 nerve roots join to form the plexus. And initially, as you can see, the C5 and C6 nerve root join to form the upper trunk. The C7 nerve root does not join any root and continues as a middle trunk. whereas the C8 and T1 then join to form the lower trunk of the nerves. So let us watch it from the anterior part. See, this was the upper trunk, this was the middle trunk and the lower trunk. Now the upper trunk, middle trunk and the lower trunk, all three of them divided into anterior and the posterior division. The upper trunk, anterior and posterior division, middle trunk, anterior and the posterior division, and the lower trunk, anterior and the posterior division. As you can notice, the three posterior division join to form the posterior cord. Similarly, the anterior division of upper and the middle trunk join to form the lateral cord, and the anterior division of the lower trunk continues as the medial cord. And with that, we conclude the basic information about the anatomy of brachial plexus, and we proceed to the various key steps of the brachial plexus exploration. So first and foremost, we start with the positioning of the patient. The patient is positioned in a supine position with the neck in extension and rotated to the opposite side. The various landmark structures are marked with the marking pen. You can see that the chest, the neck part, and the entire involved limb, in this case, the left upper limb draped, has been prepped and draped. Now coming to the landmarks and the incisions. So in supraclavicular incision, there are two landmark structures which needs to be considered. One is the sternocleidomastoid, and the second is the clavicle. So we do the surface marking of the sternocleidomastoid and the clavicle, and the incision is placed parallel to the clavicle 1.5 centimeter above it. Sometimes, most of the time, this is simple incision. Most of the time, this is simple incision is sufficient enough to explore the brachial plexus, particularly when there is upper brachial post-ganglionic injury. However, where there is a proximal level injury, in such situations, the incision is extended along the posterior border of the sternocleidomastoid so that the exposure becomes better and the proximal dissection of the brachial plexus becomes much easier. The second part is the infraclavicular incision. So in this, the important landmarks are the pectoralis major muscle and the deltoid. And you can notice that the junction between the pectoralis major and the deltoid, which can be easily palpated, the incision goes the deltoid muscle and the pectoral muscle known as the deltopectoral groove. And the incision line is given as shown. The third important part is the infiltration. So I usually infiltrate the incision line with adrenaline solution and do not add any local anesthetic agent because we want to stimulate the nerve. So only hemostatic adrenaline solution diluted to a level of 1 in 3 lakhs is injected along the suture line. Next is the exploration. So I usually inject before painting and draping so that by the time you start with the incision, the hemostasis is taken care of. Then we start with brachial plexus exploration. And in this case, I'll be showing this right brachial plexus exploration. So doing the brachial plexus exploration, different planes are raised to reach the brachial plexus. The first plane is the myocutaneous plane, as can be seen in this video. And the second plane is the plane of superficial vein and the cutaneous nerve. So here, as you can see, this is the external jugular vein and the supraclavicular nerves. Now, in some situations, if any sensory neurotization is not required, then the supraclavicular nerve can be preserved. However, in some situations where, in cases of panbrachial plexopathy, sensory restoration can be done by using this supraclavicular nerve, used as a sensory input to the median nerve. The third is the fat plane, where we raise the fat in the form of a flap, superior base flap. And then we come to the plane where the transverse cervical vessels and the omohyoid muscle lies. This plane is very important because the transverse cervical vessels need to be ligated properly. And otherwise, if there is injury to the vessel, then the field becomes quite messy. So ligation of the vessel, and then you look for the direction of the posterior belly of the omohyoid. This is a very important guide for finding the suprascapular nerve, because the suprascapular nerve can be easily found as we trace the posterior belly of the omohyoid. One important step after this is the securing the phrenic nerve, particularly when there is a lot of scarring. In such situations, it's very easy to damage the phrenic nerve. So the phrenic nerve, which lies on the anterior surface of the scalenus anticus muscle medially and passes from lateral to medial, should be secured beforehand, so that we do not cause inadvertent injury to the nerve. Here, as you can see, we are stimulating the phrenic nerve to see its integrity and then, take care of it. Now we are into the plane where the main action is. So here we identify the nerves and the different roots and the trunks. So as you can see, the first structure that comes into view is the suprascapular nerve, or the Erb's point. The posterior belly of the omohyoid muscle is almost parallel to the direction of the supraclavicular nerve. Sometimes the only structure that you can identify is the suprascapular nerve. So once you have identified the suprascapular nerve, racing it upwards, you can get the upper trunk and the C5 and C6 nerve root, as can be seen in this video. Now here I will be running a small video in which I will be demonstrating the Erb's point. And this is the point which is also known as the Erb's point, which is formed by the joining of these nerves. So here, as you can see, this is the C5, this is C6, then the suprascapular nerve, the anterior and posterior division of the upper trunk. Now all these six junction of these nerves is known as the Erb's point. At this very point is the suprascapular nerve, which originates and supplies the supraspinatus and the infraspinatus muscle. Coming next, this is a small video clip which shows the non-scarred brachial plexus exploration, where the structures are more easily visible. So here, as you can see, this is the phrenic nerve that we have secured first, and then we are going to the C5 and C6 nerve root. Here you can see the C5 and the C6 nerve root. Just below that, you can see the C7 nerve root. And when all the structures are preserved, sometimes when you need to go to the proximal part of the root, then you have to divide the scalenus anticus muscle, and then only you can explore the proximal part of the root. And because, as you can see, the scalenus anticus muscle obscures the proximal part of the root. So if you have to explore the proximal part, then you need to divide the scalenus anticus muscle, and that is exactly what we are doing here. We are dividing the scalenus anticus muscle medial part, and then you can see this is the C7 nerve root which we are hooking, and that is how you can see for the C5, C6 nerve root as well. Now, once the supraclavicular exploration is complete, then we move on for the infraclavicular exploration. Sometimes you may see that because of dense scarring, it is very difficult to identify the structures in the supraclavicular region, and you may only be able to identify either the suprascapular nerve or one or two of the roots. In such situation, instead of causing more damage, one should follow the principle of going from less scarred area to the more scarred area. And that is where the importance of infraclavicular exposure lies. So as we have already mentioned, the incision line is given between trellis major deltoid muscle in the deltopectoral groove. The incision is deepened, and where you can find the cephalic vein. Try to best preserve the cephalic vein. After that, we divide the pectoralis major muscle. And this step may or may not be required depending upon the severity of the injury or the amount of exposure that is needed. So if you need a greater exposure, then this deltoid, the pectoralis major muscle needs to be divided between two sutures so that they can be repaired later on. And after that, once the dissection goes more deep, the pectoralis minor muscle comes into vision. And as can be seen, we are dividing the pectoralis minor muscle. And once we have divided these two important structures, then comes into view the entire brachial plexus, the infraclavicular part of the brachial plexus, you can notice the different structures that can be seen. So first structure that comes into vision is the musculocutaneous nerve, and if you trace it proximally, then you can find the median nerve which can be seen as the letter M in this. So basically it is the lateral and medial contribution that it receives from the lateral and medial cord, and then they join to form the median nerve. Just behind the median nerve, you will also see the vessels, as can be seen. This is the red vessel loop, which is looping across the vessel. And as you trace proximally, just behind the vessel, you will see the posterior cord and the different branch cord which contribute to the posterior cord. This is how we do the dissection of the infraclavicular region. And once the dissection is complete, we note the findings and then make a plan for the surgical reconstruction. Thank you. So through these videos, I have tried to summarize the various key steps of the supra and the infraclavicular exploration of the brachial plexus. In majority of the situations, you will be able to access the entire brachial plexus through these two incisions. However, you may have situations where there will be very dense scarring, and in such situations, you may have to bypass that dense scar, explore the proximal and distal part of the brachial plexus, and put a bridging nerve graft in between. Also, as you know that the brachial plexus has got three parts. One is the supraclavicular, then the retroclavicular, and then the infraclavicular. In majority of the situation, you will be able to explore the retroclavicular part of the brachial plexus by just doing the supraclavicular and infraclavicular exploration. There are some surgeons who divide the segment, who take out the segment of clavicle to explore the retroclavicular portion of the brachial plexus. But most of the time, we do not need this. So with these words, I would like to conclude this video session. Thank you very much.